Yeah. And even at this age, it had found so much improvement and so many different things in last 10 years. But when I heard this, it was really that, instantly, because I think, yeah, this fact, because it fits hearing, yeah, and is main is meeting new things, new families, and I think it's still eager to yeah, even when we just have a few and the still nice and the vision has enthusiastic. And then well, for the year you like still producing has to you're going to you're really happy to be here. I appreciate your invitation, and I would do the best I can to present new idea, and I think will be beneficial to you in the future. I realize that you are real practicing, and I just want to present to you my experience and my understanding of orthopedic medicine. I am as my daughter, and he looks after me. As you get older, you have to have someone look after you. So that's what's happening. Understanding low back pain and internal disc disruption is critical. I'll tell you why during the course of my presentation. Many of you use many of these principles, but I think I can hopefully add some new ideas and that will be beneficial for all of you. I do move the slide, and I'm not doing very well. Go back to prevalence. We see patients in the middle, but I want you to know really why low back pain has become a catastrophe for many. Now, today, worldwide low back infection is the third leading cause of disability. Disability levels continue to soar worldwide. Even disability due to back pain has doubled in the last 25 years. Low back pain is not symptomatic like cancer or heat, but the effects it has on people's livelihoods and ability to work and function across every other condition. Chronic low back pain was the most common non-cancer reason for people with disabilities in recent years. The most common cause of related disability below the age of 45 is spiritual health. This is a huge pandemic across every community in the world. There, there is still no consensus on treatment for global family. We don't think it is complicated, but in the future, the more in with organizations such as this, I hope there will be a better understanding worldwide. This is 2023. The spine field has made any major progress in management of low back pain over the past several decades. There are no signs that spinal health is improving on a population basis. Despite an enormous research effort, progress in real-world outcomes has been at a standstill for more than 30 years. This is huge. And in most centers, low back pain, they call it nonspecific, and we'll go over that. The prevalence of chronic back pain and back pain-related disability both appear to be rising despite an investment of over $130 billion a year in the United States. And you say, why? I hope at the end of this lecture that it'll become clear. Topics for today: nonspecific low back pain, specific causes of pain. That is what I want to talk, and then fitness and posture, nutrition, metabolism, hormonal balance, systemic inflammation. In the future, when people come in with low back pain, they'll not only look at the immediate problem, but they will look at the total person to be sure the person is able to respond to any treatment provided. I don't know what's happening here. I'm hitting the button, but it's not really working. Well, yeah, if I could just make a note, can someone change it for me? No. Physical examination. Physical examination of the musculoskeletal system has become a perfunctory exercise by many physicians today. In the United States, if you go to an emergency room with an acute shoulder or knee problem, they may look at you, but they will not examine you. They'll take an x-ray. They see nothing wrong. Medication will be provided, and you'll be told to go to your family physician. This is not the way it should be. This is not the way it should be. Diagnosis is often primarily or solely based upon blood test, x-ray, or MRI scan. Most connective tissue or joint injuries are identified by physical examination. Many conditions that warrant a specific diagnosis are relegated to non-specific pain syndrome. I'm trying. Medical history and physical examination are essential in the initial steps in forming a diagnosis, and is especially important in musculoskeletal disorders. Always examine, examine, examine. And when you're examining a patient, always think diagnosis, diagnosis, diagnosis. It is a diagnosis that will allow you to be successful in treating that patient. The diagnostic algorithm. Observation, medical history, and physical examination are primary. It is on the basis of that you will order radiographic studies, blood tests, or do diagnostic blocks. Unfortunately, physical examination is being neglected because they have an x-ray or MRI scan. Your success in practice will be based upon your observation of the patient and your physical examination. Now, look at this, nonspecific low back pain.
Waddell, 2004. A diagnosis of specific low back pathology is only achievable in about 15% of cases. The back letter, 80 to 90% of back pain problems that come to medical attention have no obvious cause. That's not very helpful. Now, these three men represent non-specific low back pain. Always look when a patient comes in to tell you where he hurts. Always look at where he puts his hand. It is where he puts his hand is going to help you more than anything else. It'll give you the first guide to look for a problem. No, this is not non-specific low back pain. This is strain of the dorsal lumbar fascia at the posterior iliac crest. And this is the most common cause of acute low back pain around the world. This is an example of treating the attachment of the dorsal lumbar fascia to the posterior iliac crest, and as well as the iliolumbar ligament. No, let's see here. No. And, in the iliolumbar ligament, which is fine. Now, it's amazing to me how many people come in to my practice and complain of this for several weeks. They've seen physicians, but no one has looked at them. They give them medication. Treat this and they'll be well in a few days. Now, here, it's not working. Okay, now, specific causes of low back pain. The number one cause of low back pain is connective tissue injury. Number one cause. Where and how will be determined by the examination. The number two cause is discogenic pain. And discogenic pain more commonly can be classified as internal disc derangement or dysfunction. And it is this condition that most doctors miss because it is not seen radiographically, but it is identified clinically if you know what you are looking for. Now, when you combine connective tissue injuries with discogenic pain, what happens? You initially develop instability of the lumbar spine. Instability can affect lumbar 3-4, 4-5, 5-1, or the sacroiliac joints. You must be aware of that if you plan to provide a total treatment program for the patient. Now, instability. When it is allowed to proceed, it causes spinal stenosis, most commonly at the L4-5 level, most commonly at the lateral recess. I've seen this over and over again. Then you realize that this did not have to happen if the patient were treated years ago, and I'll show you how that can be done. Now, when this slide to me is extremely important. It is you should have this in mind all the time. The fibroperiosteal junction. Injury to the fibroperiosteal junction at the connective tissue attachments to bone. The fibroperiosteal junction is relatively weak and is common site of musculoskeletal injury and chronic pain. This is the number one site of connective tissue injury, but not the only site. The periosteum, I want you to realize the periosteum comprises two layers. The deep layer is composed of fibroblasts, and if injured, bone spurs occur. And the superficial layer are blood vessels and nerves. Now, myofascial tendon and ligament injury. This is huge. And I want you to always think of this when you're examining a person. It is micro or macro tears to muscles, fascia, tendons, and ligaments. It is these tears that can cause a huge amount of pain in every peripheral joint that you can think of. Now, micro tears are frequently present just proximal to the fibroperiosteal junction. And if you're using a needle, you will feel that right away. And once you know that, then you'll know that you have to treat the fibroperiosteal junction as well as the micro tears. This can be important in many patients. Now, micro and macro tears can occur within the body of a tendon or ligament with a localized inflammatory reaction causing chronic or recurrent pain. You see this frequently in the shoulder. This is one of the reasons when people have so much trouble with dealing with shoulder problems. Muscle injury usually involves surrounding fascia. Now, this is also important. That can cause sensory and sympathetic nerve entrapment, leading to trigger points and spasm of muscle. When I was younger, they told me that the muscles were not the culprit. It was a ligament or the joint capsule that was the culprit. That is not true. The ligament and joint capsule are the first to be injured. Then the body automatically wants to protect that joint. Muscles then go into spasm protectively. If there is too much spasm, you get inflammation, especially in the fascial bundles that surround the muscles. What happens? Sensory and sympathetic nerve C fibers become trapped. You either will have a trigger point or you'll have a muscle bundle that is contracted and is painful and prevents you from using the shoulder properly, the knee or hip properly. Now, I'll go over more specifically with nerve injury. Nerve injuries frequently occur in muscles and fascia where unmyelinated C fibers, sensory and sympathetic, become trapped in scar tissue, inflamed fascial planes, areas of chronic muscle spasm, causing the C fibers to become persistently depolarized. They're depolarized and a source of pain and additional muscle spasm. I want you to remember this: fibroperiosteal junction, micro and macro tears, and nerve injury. Every time you see a patient, for whatever problem comes your way, always think of this. Don't think, oh, everything is painful. Begin to think of what structures were injured, and then you can focus on dealing with the patient more easily. I'm trying. Here. Now, again, collagen fibrils, this is the key here. The union of two dissimilar materials is potentially weak. That is the fibroperiosteal junction. Microscopic failure of collagen fibrils begins to occur after there's happened a greater than 4% elongation. Macroscopic failure with tears with complete disruption occur at 6% elongation. You can see various injuries when the shoulder or the hip or the knee are injured. This is what happens. Oh, I say that. I'm sorry. This is what happens. I'll remember. Now, I'm trying. Now, the intervertebral disc. This is a mystery for most people. The surgeons think they understand it fully. They do not. At the end of this talk, I hope all of you will have a much clearer understanding of the intervertebral disc. Now, first, annular tear. Most annular tears are without pain, and they are due to degeneration and repetitive stress. Annular tears caused by trauma become painful when a nuclear fragment secreting inflammatory cytokines becomes trapped in the tear that extends to the periphery of the disc, exposing sensory nerves. That is what happens, and I'll show you later how this happens. Disc degeneration unto itself is not painful. Disc degeneration becomes painful when motion segment instability is present, causing neural irritation and pain within the disc annulus, about the disc periphery, and adjacent nerves, and is often associated with facet joint subluxation. Nearly everybody in this audience has a degree of disc degeneration, and most of you have no pain at all. But it's when you have injury to the nucleus with tears in the annulus that you have pain. Now, a disc protrusion is usually without pain. I will show you an example later on. The protrusion becomes painful when an annular tear extends into the protrusion with a trapped painful nuclear fragment. Soft disc herniation. When in teenagers, usually it will be resorbed because it's a very soft disc. Hard discs in older people need to be removed. Now, internal disc disruption. A common cause of central low back pain with or without buttock and leg radiation is caused again by a nuclear fragment post-trauma, wherein the cells are secreting inflammatory cytokines and matrix-degrading enzymes. This is huge. This is huge. This is missed by nearly everybody. Nearly everybody. If all of you go away into your practice and you have this in mind, you're going to be so pleased to be able to identify these problems. And then you'll know what to do about it from a simple way to a more difficult way. And we'll discuss that as this lecture proceeds. Now, there's a combination of internal disc disruption and degenerative disc disease. Now, the last one, motion segment injury, is usually a temporary issue with trauma and can be very well treated by caudal epidural block. I'm trying. There. Lumbosacral spinal canal inflammation. It's not obvious unless you look for it and if you understand it. I've seen many people, older people, who have a degree of instability at L4-5 or L5-S1. They do some vigorous activity that stretches the dura underneath and within the spinal canal. Spinal canal becomes inflamed. You identify central pain. The straight leg raising test is not necessarily positive, but it gives a sense of resistance. And every time you do that, you'll begin to understand how to identify this clearly. The next is inflammation of the dorsal root ganglion due to neuropathic pain. This is a huge problem. When it's present, most people do not recognize it, saying that they have neuropathic pain in the leg. They don't know where, the disc look okay, but it's not the disc. It's the dorsal root ganglion within the foramen before the nerve root exits the spine. Spinal stenosis, certainly. I've seen several patients over the years who have thickened ligamenta flava. You wouldn't think so, but we identified that and that was removed and their symptoms subsided. So always think of that as a possibility. Lateral spinal stenosis is usually in the lateral recess, narrowing due to thickened facet joint capsules, protruding disc annulus, and bone spurs. Nearly all of these problems occur at L4-5. It can be above and below, certainly, but L4-5 is the common. I'm trying. No. Conditions contributing to low back. And all of you who are in a clinic treating, you're always looking for hypermobility syndrome. The worst is Ehlers-Danlos syndrome. Women have it far more than men. and it can become a major issue if you do not understand it. Aging, certainly. That limits healing. Trauma and repetitive stress. Now, posture and fitness. Posture and fitness. She's keeping me honest. Is huge. And when you see patients, if you're able to advise them on improved posture if necessary and becoming more fit, it'll make a huge difference in recovery. Nutrition and digestion are major factors. I've seen in the past many auto accident victims who have chronic neck pain. We tried to do prolotherapy. They improve, but not satisfactorily. They change their diet and add protein, sufficient protein. They begin to heal. So it's not just protein, but it is a well-rounded diet. Metabolic dysfunction, such as hormones. Today, I've seen many young men in their 30s and 40s. They just don't look right. They have low back pain. And then we test them for testosterone levels, and they're way low. By just changing that and adding nutrition and so forth, they heal. Women, you have to have an adequate progesterone estrogen balance. There was one lady, I recall, she gave birth to her second child. She was in her 30s. She had severe low back pain for a year before we saw her. They couldn't understand why she had so much low back pain. Yes, she had injured the ligament supporting the pelvis. Yes, that could be treated, but she did not get fully well until she was provided progesterone. At age 37, within 6 months, her pain was completely gone. So you have to think more broadly when you do orthopedic medicine. And one of the most important things is for the physician, hopefully, to provide an attitude for recovery. Now, persistence of pain. This is simple. I will go over this briefly with you. Young people become injured. They get better. They do not get well. They don't move as rapidly. They still have aches and pains in the back or the knee. But they're not doing anything to recover, either by exercise or by nutrition, nothing. They get injured again. They come back to you, and you find their symptoms are a little worse. And this is persistence of pain. When you see a patient, you want to urge them to regain as much health and fitness as possible over the time that you're treating them and beyond. This is huge. I want you to look at this very carefully. For the low back, this is a major factor in getting well. Passive stability, ligaments and joints. Dynamic stability, muscle, tendon, and fascia. We'll go over this in detail because this is the key of getting a person very well versus partially well. Now, the passive stability. I'm going to repeat these ligaments to you. Now, people think automatically, oftentimes we inject here and here, but they don't really know why they are injecting this site. The iliolumbar ligament is extremely important in providing stability to the fifth lumbar vertebra. Very important, but it also helps stabilize the L4 vertebra. Now, the posterior sacroiliac ligaments, yes, we can understand that. But now the sacroiliac interosseous ligaments. Sometimes a needle can be placed into that interface. And usually on one side or the other, you can get into the interface. this is a critical ligament for stability of the sacroiliac joints. Now, the sacrotuberous ligaments. Personally, I've yet to see anyone focus on the sacrotuberous ligaments. I will show you how later. The sacrotuberous ligaments works hand in hand with the gluteus maximus muscle in providing posterior stability and keeping the pelvis forward. There's a great number of muscles that are involved in this, but this is a major muscle. This is a major ligament here. And then we have these lumbar facet joint capsules and supra and interspinal ligaments, which are important as well, but not as much as the ligaments I just. Now, okay. Dynamic stability. When you look at the back, and you focus on the painful area, but I just want to bring up to you these muscles that are extremely important for dynamic lumbosacral stability. First, the posterior spinal muscles, iliocostalis, longissimus, and spinalis. Each one has a different function, but they all work together. The latissimus dorsi, most people don't think about it, but it's a major support for the lumbosacral area. The quadratus lumborum, people don't pay attention to it, but the insertion sites are on the tips of the lumbar spinous processes from lumbar 1 to lumbar 4 and the inferior border of the 12th rib. Now, posterior abdominal muscles, so is major, so is minor, and iliacus. Yesterday it was Lenny who reminded me that the iliacus has more than a flexion of the thigh function. It's a stabilizer for the hip joint, and he will discuss that at length tomorrow. Now, anterior abdominal muscles. We agree with the rectus abdominis. It's obvious. But the external abdominal oblique, the internal abdominal, and transversus can also be important, and I'll show you how. Now, the buttock and posterior thigh muscles, the gluteus maximus major. Now, the gluteus medius and minimus, you don't think so much, but they provide stability to the hip joint. And when the hip joint is stable, it's easier to maintain stability of the lumbosacral area. The hamstring muscles are extremely important. Why? They arise from the ischial tuberosity. The ischial tuberosity is also the origin of the sacrotuberous ligament, the origin of the rectus femoris muscle. There are other muscles around it, but those are the three that you should remember. And so these muscles, again, help stabilize the pelvis. The anterior thigh muscles, rectus femoris, you can understand because it attaches to the anterior inferior iliac spine. But also, the vastus lateralis, vastus tenuis, and vastus medialis. You say, why is that? Why? Doesn't make sense. It's an anterior thigh muscle. The upper end of those muscles are attached to the intertrochanteric line that goes from the greater trochanter downward. And what also is attached there, that's the iliofemoral ligament, the primary supporting ligament of the hip. But that ligament is crucial for function of the hip joint. And when we talk about the hip, you'll understand why. You notice on your right, you see the latissimus dorsi. It becomes attached to the spinous processes from thoracic 6 down to lumbar 5. It also is attached to the dorsum of the sacrum. But look here. It also is part of the gluteus maximus muscle. When these muscles are functioning, stability. And that is what you're looking for. here on the left, you see the paraspinal muscles. You see the iliocostalis, the longissimus, and the spinalis. And look where they attach, to the sacrum and to the posterior iliac crests. Extremely important. You see the posterior inferior serratus, the serratus posterior inferior muscle on your left there. That is a major muscle, if you understand it, to the upper lumbar spine. And what I want you to do is when you look at a joint or you look at the back of the neck, try and have an idea of the various muscles, what they do and how they can become more functional to provide stability and support. Now, look over here. You have the quadratus lumborum. It's a major muscle, but very few people even discuss it at all. Anteriorly, you see the rectus abdominis, but here the external abdominal oblique, internal abdominal oblique, and transversus. Now, they provide lateral stability, but we're really not worried about it. But if you want to rehabilitate a person, you want all of these muscles to be functioning optimally. Now, you can see on the left how they all relate to the rectus abdominis muscle. And on this side, you see the quadratus lumborum here, the psoas major, psoas minor, and the iliacus. Now, the iliacus is different than the psoas major. The psoas major goes down straight away and attaches to the lesser, the lesser trochanter here. The iliacus is different. The iliacus first attaches to the tendon of the psoas major, but more importantly, the hip joint capsule. And then when it becomes attached to the lesser trochanter, it continues downward for about 2 centimeters. It is a major stabilizer of the hip as well as the back, and Lenny will talk about that tomorrow, I believe. Now here, the gluteus maximus muscle. It's a major muscle. You see below it, the hamstring muscles. But now look on the right. You see the sacrotuberous ligament being attached to the medial side of the ischial tuberosity. That fascia attaches to the hamstring muscles. You see the biceps femoris laterally, then the semitendinosus, and deep to it, the semimembranosus. But look on the lateral side. You see the quadratus femoris. Above it, you see the obturator, well, you don't see the externus here, but you see the obturator internus, the gemelli, and the piriformis. Those muscles are all important, and they work together. So always think, when you look at the hip, always think of these as a unit. This is different. Now, stability of the thigh, certainly the sartorius and the tensor fasciae latae. But again, look up here where the quad muscles attach to the intertrochanteric line and the iliofemoral ligament. This is a major area. And when it comes to the hip, I promise you, very few people understand how to treat a hip effectively. I did not know. I know now, and I hope to show you what I know. And I want you, I'm sorry, and I want you to, thank you. Please, I gotta do this. I want you to know. Now here, obviously you see the sacrotuberous ligament here. It's major. This is the major attachment right there. We've been able to turn around a large number of people with lumbosacral pain when we began to realize the contribution of the sacrotuberous ligament here. Up here, what you don't see is the interosseous ligament. People don't pay attention to it. You want to pay attention to that ligament. And if the needle will go into the interface between the ilium and sacrum, you know that patient is going to get better. Now, this is a little rectangle. This is where all the action is. Now, oh, I can do it here. I'm learning. Well, I'm trying. I need another hand. Oh, that's all it is. Yeah, all right. When you look at this, I want you to see here, right here, the dorsal lumbar fascia here, the quadratus lumborum here, and the outside, the latissimus dorsi, they all are here. Then up here, you have the external and internal abdominal oblique muscles here. This is huge. It is deep in here that you see the interosseous ligament. You always want to think of the interosseous ligament, because if you don't, you're not going to get the success that you want. And that goes all the way down to here. Now, again, the sacrotuberous ligament that comes here, goes up laterally and attaches here. And Lenny feels that there's a relationship between the sacrotuberous and the piriformis muscle that comes out here. And he will discuss that later. But once you begin to understand this, you'll be much more successful in prolotherapy, much more. And I think this is extremely important. So let us go here. Dorsal-lumbar fascia, iliolumbar ligaments connecting the L4 and L5 transverse processes, the interosseous ligaments connecting the tuberosity of the ilium to the tuberosity of the sacrum, the sacroiliac joint and overlying posterior sacroiliac, and the sacrotuberous ligaments from the ischial tuberosity to the posterior sacral margins and then to the posterior superior iliac spine. Certainly the facet joints and the superior and interspinal ligaments. Now, when you treat a low back, you're not going to treat everything. You treat that which presents to you. But you want to have in mind all the structures that you should look at or be aware of when you are treating, because we have been able now in our practice to turn around many people when we looked more broadly, especially when we looked at the contribution of the sacrotuberous ligaments from here to here to here, because this is what provided, this is a major source of support. Now, got to figure out where we'll proceed. Again, I want to show you the dorsal lumbar fascia coming all the way down to the sacrum, coming up to the posterior ilium by the latissimus dorsi, and then underneath it, the paraspinal muscles. But now let's go. Here, the iliolumbar ligament. It's a critical ligament. And when you're treating, I want you to always think in terms of the transverse process of L5 and placing the needle parallel into that ligament. And you can always find it. You can always find it up here. And this is a major ligament. Next, you see the quadratus lumborum. We just highlighted this to see the transverse process attachments. Most people will not pay attention to it or just mechanically inject the transverse process. But what you're doing, you're stabilizing this ligament, and you're also going to stabilize it along the posterior iliac crest. Here, look at number 2, the blue. That is the interosseous ligament. When you're treating the lumbosacral area, you do your best to place a needle into or near that ligament. because that is going to be your success. Here, the sacrotuberous ligament. I commonly now will inject the ligament here along the margin of the sacrum all the way up to the ilium. And by doing that, you're also injecting the attachment of the gluteus maximus muscle here. You'll find if you add that to your practice, you're going to be very happy in a large number of patients. These are other pictures of the sacrotuberous ligament. You can see it coming down here. You can see the hamstring muscles there. You can see the quadratus femoris coming this way. And this is just another picture of it, but we'll continue. Now, stability of the lumbar motion segment is largely due to the integrity of the myofascia and ligaments about the spine. L3-4, torsional stress. L4-5, torsional stress. And it is the most common site for spinal stenosis in the lateral recess. And L5S1, which is subject to shear and compressive stress. When you're treating a patient with prolotherapy, always think in terms of stability, not only of the lumbar motion segments, but of the sacroiliac joints. Well, this is another picture identifying the supra and interspinal ligaments, which also should be treated, especially if there's tenderness, and commonly at the L5S1 because there's a shift between the sacrum and L5 commonly. Now, connective tissue can be, and joint injuries can be mild, moderate, or severe. If pain is mild to moderate, nutrition, improved posture, and gradual effort and motion modality stimulus can solve many problems. When pain or dysfunction are persistent, affecting daily activities, directed treatment should be initiated. Prolotherapy, an injection treatment to stimulate repair of injured connective tissue by collagen proliferation, commonly at the fibro-osseous junction. Oftentimes, when you see a patient that is extremely inflamed, and it's very hard to identify what structures you want to proceed with, it's reasonable on the first treatment to disinflame the areas of concern. And this is just what I use. It can be any combination. I use some dextrose, lidocaine, usually bupivacaine or ropivacaine and Kenalog 10. I never use concentrated Kenalog. I use at most 1 cc in a 10 cc syringe. Now, promote circulation and stimulate repair and healing. I've used dextrose prolotherapy for my entire life and continue to do so. Usually a 10 to 25% concentration with local anesthetic has been the mainstay of treatment for many decades. The solution is basically safe and is usually effective. Glycerin up to 20% can be added to further enhance repair. I use glycerin and it works. Platelet-rich plasma in various kinds is effective. Each sample has a variable mix of growth factors. The vitality of the sample is often dependent upon age and health. From 6 to 8 milliliters can be obtained from 80 milliliters of blood. I've never done this. I know many physicians who have. It can work. Is it better than dextrose? Maybe. It's better if the patient is healthy and vigorous, and if you have an accurate diagnosis, you know what you're treating. Now, the future development of appropriate growth factors will significantly enhance treatment possibilities. Research work is now being done, and once this is accomplished, you will find that your ability to treat many difficult problems will improve dramatically. This is a study we did a few years ago. I want you to look at series 2. We added transforming growth factor beta 2. Then we combined it with that fibroblast growth factor, and you look at the reaction was huge. This is coming. When, I don't know. but it will be in your lifetimes. And I think this will be a tremendous adjunct for all of you to use effectively. Now, this is a picture I just wanted to show you of the many red dots that I put together to show you how to treat. I nearly always treat here. This can be done simply and directly. You just have to see it done once, and then you'll know how to do it. Then certainly the sacrotuberous ligament, the dorsal lumbar fascia, and all the other ligaments and structures that you have. Now, disc degeneration, first seen in 13-year-olds. It doesn't have to be painful, but degeneration does occur in nearly everybody to a varying degree. Oh, no. Now, common sites are C5-6, T6-7, lumbar 4-5, and 5-1. C5-6 can be a major factor in problems with the neck, especially in later life. We can discuss that later. Oh, God, no, I want to go back. Yeah. Okay. No. Yeah. Now look at this. Stanford Health Department of Radiology. 40 to 60-year-olds who do not have back pain, an MRI will find that about 8 in 10 have disc degeneration, 7 in 10 have disc signal loss or desiccation, 6 in 10 have disc height loss, 6 in 10 have a disc bulge, 3 in 10 have a disc protrusion, and 3 in 10 have an annular fissure. This is important because everybody has this. It is the physical examination and the history that's going to tell you if these are problems and need to be treated. 2 studies from Korea found disc herniations, annular fissures, and nuclear degeneration in more than 80% of adult subjects evaluated with no history of back pain. Neural therapy. This probably should have been in a different place, but neural therapy is a wonderful adjunct to prolotherapy. All you have to use is a local anesthetic. You have nothing more, 0.5% lidocaine. You can add a small amount of dextrose, a little bit of Canalog 10. You use that to treat the muscles overlying joints that are being treated with prolotherapy, especially if there's muscle spasm. Now, disc bulges are seen in more than 1/2 of asymptomatic persons. Disc protrusions are seen in more than 1/3 of asymptomatic persons. And spinal stenosis is present in more than 20% of older people. Now, disc bulges, well, we'll continue. Now, disc bulges and protrusions become painful when there is a penetrating annular tear with trapped inflamed nuclear material. You will see this. You won't know fully because sometimes you need to have special tests, but now, Spinal News International, when degenerative disc disease is present, up to 40% suffer chronic discogenic pain, often with secondary neurological disorders, mostly chemical irritation. It is pain that should alert the physician to possible discogenic disease. Careful medical history and physical should indicate to the physician the presence of discogenic disease. Confirmation of IDD is by MRI scan and CT discography. The concept of IDD was introduced by Henry Kroc in 1970. 1970, that's 50 years ago, but it hasn't. It's not understood by the majority of people. Internal disc has been defined as lumbar spinal pain with or without referred pain stemming from an intervertebral disc caused by internal disc disruption of the normal structural and biomechanical integrity. Now, this is his textbook. If ever you find it, buy it. It's a classic. This is a classic text. Now, I want you to look at this. This is history. It's a very important history. 1934, Mixtenbar first described disc herniation. 1941, Dandy, a surgeon, alluded to his disillusionment at failing to detect a herniated nucleus bone in an overwhelming number of patients with recurring attacks of low back pain and leg symptoms. He believed that in a large majority of these patients, the source of pain was a concealed ruptured disc. He didn't know what to do about it, but they saw this in 1941. 1948, Hirsch relieved sciatic pain following an injection of Novocaine into the disc. Then Fernstrom in 1960 observed that a single ruptured disc without herniation can have a clinical presentation similar to a herniated nucleus pulposus. Pain from these discs had a deep somatic and referred pain, and referred lower extremity component. 1992, Schwarzer, April, and Derby, disconcerting are a large number of chronic low back pain subjects with painful, albeit normal-looking discs. Now, these are surgeons. These are spinal interventionalists. They see a certain group of people. It's not a small group. It's a large group. And you, seeing mostly people from the street or from local referrals, you will find that there will be a certain number of patients that come your way that are going to have these problems. Right now, there is no specific treatment, but in the future there will be, and you as physicians will be able to either treat them yourselves or have people treat them for you. Now, I won't go over this too much. The condition is common and should be readily identified clinically. The clinical syndrome may be associated with this type of disorder, usually follows severe trauma inflicted on the disc by sudden unexpected weightlifting or by auto accident. People who do heavy labor repetitively and begin to develop low back pain, this often is the case. Now, he listed the following: usually caused by severe or repeated episodes of trauma. Back pain is prominent, having a character of a deep-seated ache. Pain is aggravated by activity. This is critical. Spinal manipulation. Prolonged sitting can be very painful, as well as forward bending. Let me go back. These are additional complaints. I've seen 3 or more doctors, and nobody can tell me why my back hurts. My low back pain is deep and in the middle. I have numbness and tingling in my lower legs. My back pain sometimes just goes out and takes days to get better. I have pain, burning, and numbness in my genital area that spreads to my medial thighs. When you see that, you know it's an L5-S1 disc affecting the S1 and S2 nerve roots. My MRI is negative, but I have leg pain. You see, there's so many questions that if you're aware of this, and you'll now have them in your handout, that this will be of help to you. Now, this is what I put together, and I think this is accurate, but I will repeat a little bit. IDD is painful due to a traumatically induced chemical reaction within the disc caused by injury to the nucleus pulposus, and usually there is an associated annular tear. There is fragmentation of part of the nucleus, where the fragmented part loses its connection to the surrounding tissues. The nucleus pulposus cells begin to degenerate, are then called senescent cells. These cells secrete inflammatory cytokines and matrix-degrading enzymes, causing degeneration of the disc. These cells eventually die, which can take many years. When an annular tear extends to the outer third of the annulus, sensory nerve endings are exposed. When they come in contact with the inflamed nuclear fragments, an inflammatory cytokine pain occurs, local or referred. Now, if an annulus is completely ruptured, the inflammatory cytokines and matrix can spread into the spinal canal and then migrate throughout the body. And this is seen in many people. Disc injury affects the annulus as well. And you can have a singular tear or multiple tears. Now, when the disc injury becomes chronic, usually after several years, generalized disruption of the annulus often occurs, increasing disc instability and leading to a combined condition of chemical inflammation from a fragment of the nucleus and structural instability of the annulus. I've seen this often. Now, this shows you, based on animal models, when you have an inflamed disc fragment, inflammatory cytokines increase, matrix degrading enzymes increase, matrix proteins and cell viability decrease. No, I want to go back. I want to show you. This is a patient of mine. I've seen him for 5 years. We finally got him pain-free. 2015, he slips in the shower, lands on his butt. Severe central low back pain, never went away. A year later, he trips, lands on his right knee and twists his back. He had a mild case of MS, went to several neurologists, trying to figure out why he had so much low back and right leg pain. They looked at this and said, this has to be due to MS. The wife said, why? Didn't have the pain before he had these 2 falls. Finally came and then a CT disc scan was finally done. And as soon as I examined him, I knew right away, this is internal disc disruption. Pardon me, as soon as I examined him, I knew this was internal disc disruption. I didn't know how many levels, but we did 3 levels. The lower 3 lumbar discs were concordantly painful. L5S1 shows circumferential annular disruption here. L4-5 showed 2 annular tears, painful. L3-4, painful. You knew why the man had the pain. Now, this is 8 years after he had his falls. Seeing a multitude of doctors, and not one doctor had the foggiest notion what was wrong with him, except it must be your MS. Now, you see this. In your practices, when things don't look right, always re-examine and begin to think of all the possibilities that it can occur in the low back. Now, you see this? That is a fragment of a nucleus removed surgically by endoscopic surgery. It looks bland, doesn't it? We've had a number of patients that once this fragment is removed, their discogenic pain subsides dramatically. Now, here's another, this is from a young man. Not always, but commonly, you would inject methylene blue into the disc. The methylene blue will be absorbed by the disc, by the nuclear fragment, and it will show up blue, but the normal nucleus will not. And this is another picture, and it took a while in another presentation I'll show you, but he was 22. He had pain for 2 years. He saw about a half a dozen surgeons. Not one wanted to operate on him, and not one knew what the problem was. Not one. Now, you're the first to see this. I want you not to forget it. This is a microscopic picture of a disc fragment. You say there's no blood vessels, there's no sensory nerve, there's no nerves in it at all. You're looking at senescent cells. These are nucleus pulposus cells that are in the process of dying. And in this process, they're called senescent cells. And they secrete inflammatory cytokines and matrix degrading enzymes. That can last for 10 or 20 years. And everybody who has a disc injury will say they get better because these cells are, when they die, they don't secrete anymore. But this is the first. Now, these are 2 studies that I've been involved with. This is done in Canada. Molecular therapy for degenerative disc disease, clues from secretome analysis of the notochord cell-rich nucleus pulposus. This is the follow-up, and if you notice, my name's on the back, so I was very happy with that. You know, I got my name on a paper, so I thought that was a good deal. Now, I want you to look at this, an animal study. On your left is a normal rat nucleus, normal rat nucleus. They took a series of rats. In one group, they damaged the disc with placing a strong needle through the disc several times. They waited several weeks, then they did a discogram. They made sure that they were dying here. Half of them were injected with saline, the half of the connective tissue growth factor and transforming growth factor beta 1. Look at that. The nucleus returned to normal. Nucleus returned to normal. How many people out there do you see that have chronic discogenic back pain? It's huge, mind you. It's huge. We're not ready. It's not ready for the prime time, but hopefully that this can, once these growth factors are available, they can be injected into the disc, and you're not going to have surgery. But you're going to have to look at stability of the lumbar spine through prolotherapy. Prolotherapy will be improved dramatically once you can add growth factors that are manufactured recombinantly, so there's no problem with allergy. This is really huge. And I want you to understand it now. The future. Endoscopic disc surgery is very effective. I'm sorry. Endoscopic surgery is a very effective surgical procedure. It requires much skill. The learning curve can require several years to master. Availability is very limited. There are conditions of IDD where endoscopic surgery cannot be used. Internal disc disruption is basically a chemical reaction following trauma. A solution to inject into the disc to quell chemical inflammation, promote healing would be ideal. When available, this should be considered before any surgical intervention. The reduction of systemic inflammation, if present, and the enhancement of metabolism are very important components for full recovery. The physician should be aware of the nuances of internal disc for the best treatment and outcome. Tissue growth factors will become the mainstay of successful treatment. Today, many efforts are being made to develop a solution for disc treatment. Eventually, this will be successful. That's this talk. It's probably a lot for you. I don't mean to talk too much, but look. Hello, can you hear me? What you have learned today is that when you look at the low back pain, you want to have in your mind where the pain is located and what is primarily contributing to the pain. Then you want to look at those ligament structures that are essential for stability, the muscles that are essential for stability. Then you will do specific treatment to help repair damaged tissue. But in your clinics or in your practice, you will want to have people exercise properly. You'll want them to be on a good nutritional program and the like. Now, discogenic pain is not uncommon. You will see discogenic pain because people will come to you with chronic low back pain. And when you are aware of internal disc disruption, at this time, you may not be able to treat them directly. But there are a group of people that suffer this that are generally healthy, that can improve by diet, by very controlled exercise, basically to stimulate perfusion through the end plates. That takes time, but it can be done. Now, in the future with growth factors, you are a winner. You're going to be at the forefront of treating people with low back pain. And you're going to know how to do it. You're going to know what to look for. By having that in your hand, you're going to be able to contribute to your immediate patient base, but you're going to be able to contribute to the community. That is what you want. The one thing you do not want in medicine today is to be mechanical. It's being mechanical that when everything is okay. It should never be okay. You should always be looking for a better way to treat a person to make that patient healthy again. If you can do that, you are a winner. Now it's break time. And when should we start again?
Yeah, maybe we can do a short break if you like.
What? I don't hear. I'm sorry. What?
If you want to break it now?
Yeah, no, we can. If it's, I hope I didn't keep you too long.
Our schedule will be
What do you want me to do?
three, but if you want break,
One more?
then maybe 大家休息了，需要
I can certainly show them. Oh,
再休息。
can we have the case presentations? We can do that. and then-
对，要继续还是要休息？大家觉得举手一下好了。OK，那我们we can keep. We can
Keep going?
Yeah.
Okay, we'll do case
Okay.
presentations.
Yeah, case presentation.
Since you know about discogenic disease, I want to show you what happens in the real world. And when you see this, you're going to say, wow, look at this. So, well, I'll wait for this and take a little water.
有人有问题？Someone have question also. You can ask. We go into the case presentation, but we will see how beyond fear because the travel a lot, and if he want to break, we'll do a break. 那不是那个，不是那个 case demonstration，是 case study 哦。那个 slide。是继续讲课，继续讲课。Any question about the topic?
Thank you, Dr. Bayon. Thank you for your amazing lectures. Yeah. Oh. Okay. Thank you for your amazing lecture. I have one question. You've mentioned before that there's a lot of people with this degeneration, this problem, but without pain. My question is, if we accidentally find this problem in a patient from MRI, for example, but the patient doesn't complain about pain, so should we also give fluorotherapy to prevent the pain? Thank you.
Tell me if I got it. Hello, can you hear me? Yes, you can. I think the question is, you have a patient who has L5S1 discogenic pain, correct?
No pain,
No pain.
no pain, just problem from MRI. This maybe bulging this like that.
If he has no pain, it's hard to say we'll treat you. But let us say he has an L5S1 disc that is collapsing. Is that correct?
Yes.
Now, if he said he had some pain on forward bending, lifting, and the like, yes, prolotherapy can be of help. But what you're doing now, you're looking to see what structures are, are going to contribute to stability of the L5S1 level. One would be exercise, to strengthen as many of the muscles in the back and buttock as you can. Now, when you see L5S1 as being a weakness, always think in terms of the iliolumbar ligament, interosseous ligaments, and the sacrotuberous. Why the sacrotuberous? Because you want to be up like this. It'll take stress off the posterior part of that disc. You can tell him this is preventative. And again, if you have a clinic where you can, you can advise in nutrition, lifestyle, that's the best way. That's the best way. And if he has no pain, he's lucky. But your job is to keep him out of pain. And that would be simple things. But then prolotherapy can help. I've had many patients where they have a certain degree of lumbar pain, and we do prolotherapy, not to say that we're going to cure you, but make you more stable. But we do that in concert with exercise and posture and nutrition. Okay?
Okay,
Yeah.
thank you.
You're welcome. What here? Are there any other questions? No, I'm okay. I'm okay. Don. While they were organizing this, I want to show you a series of patients. Some that were treated very effectively, some not. And most of these patients came to me after the fact when they had surgeries. And we were able to help them dramatically by treating the soft tissues. But it is, I think it is people who do orthopedic medicine. You should be in the forefront of identifying discogenic problems and being able to advise how most effectively to treat them, if surgery is required, if surgery is not required, and how to get the best end results. That is what you want. I can start out with this patient. Okay?
And this forward, backward, and this is point.
Oh, okay. Okay, thank you. Trying to go forward. Huh?
That's just share them.
Can you hear me? Yes. This case never should have happened. Never. He was told at the end of this surgery that in 12 months he'd be fully well and fully functional. This occurred circa 2000. He's totally disabled today. He can function, but he can't stand long, and he has to be very limited in his activities. This case was an internal disruption case. If it was understood, and even if they did CT discography early on and had they would not have found all of these discs to be painful. Only one, L5S1. He was a Marine Corps pilot in his youth. He landed on aircraft carriers many times in a jet airplane. When he retired from the Navy or the Marine Corps, he was very active playing softball and the like. We saw him initially in the mid-90s, and we treated him with prolotherapy. It allowed him to become fully active again. Then he was in a major auto accident, back pain and leg pain. Back pain and leg pain. Initially, they thought in those days they did CT disc, no, they put a catheter into the disc and heated the annulus. They don't do that anymore. It didn't work. Had it done twice, it was more painful. He went to a major university. They only looked at his MRI scan, saw 3 black discs. You need a spinal fusion. You need a spinal fusion. That decision was made within just minutes. He was hesitant, but he said, geez, I have pain. Then this was done. Never better. It never should have been done. Today, with what you know, what you've looked at here, you would have said, is there internal disc disruption present? But he went to a major university, they had residents, they wanted to do surgery. This is actually what happened. Major university in California. I don't know what's wrong. Oh, now look. There's a whole story to this. There's a whole story to this. He got an infection in one disc because of all the things that were done. Look at the bone graft. Today, I see him monthly just to disinflame the tissues around the bone graft. That allows him to function. This is 20 years. It never had to have been done. But the surgeon said, this is a wonderful event, but it was terrible. Now, obviously surgery is improving. But when people say for degenerative disc disease, you need a multi-level spinal fusion, think twice. When you don't have the tools to go in and further look into what could be happening, it's a problem. I understand that. But here, CT discography, and if we had growth factors for the discs, he would have been normal today, functioning normally. Oh, this is a little bit of his history. Joined the Marine Corps, became an F-14 pilot, more than 2,000 flight hours, many aircraft carrier landed, hit the deck. You hit the deck at 120 miles per hour, and you come to a stop within 130 feet. So that's a lot of stress on the back. Oh. 1994, he had increasing low back pain. Low back prolotherapy, became pain-free. In 1995, he participated in the American Gladiator contest, which was a big TV show in those days. Now, no low back pain. Age 45, 1998, auto accident, was stopped, was driving a new Chevrolet pickup truck with extended cab, was rear-ended by a vehicle going about 80 miles an hour. Hit car in front, extended cab was crushed, developed severe low back pain and right leg pain. Now, epidural blocks were done. This was a time when I would say we didn't really know what to do. Today, you should know exactly what to do and how to save this person. Yeah. Oh, I'm sorry. Yeah. I have to be reminded. I'm not, I'll learn this when now, lumbar spinal, so 2IDET procedure, that was an intradiscal electrothermal therapy, was popular circa 2000. It burned the annulus. They thought by burning the annulus, you'd kill nerves and coagulate collagen. It didn't work. And his first treatment helped, but when they said the second was done with increased heat, it made him painful. June 1998, lumbar spinal cord stimulator to lessen right leg pain and avoid surgery. Didn't work. UCLA Spine Service recommended 3-level anterior posterior fusion should be essentially pain-free in 6 to 12 months. Age 47, posterior spinal fusion, L3-4 to L5-S1. I'm going to read this to you so you see what happens to people. I want you to know what happens to people when they don't understand the problem. Oh, yeah, May 11, anterior interbody fusion, L3-4 to L5-S1. Had severe pain for several weeks, right leg pain persisted. Morphine pump installed, constipation, leads cause a disc space infection at L2-3. November 2000, removed hardware, no pain relief. December 2001, removed spinal cord stimulator and morphine pump, no pain relief. February 3, 2002, recurrent L2-3 disc space infection, surgically removed part of disc and vertebra. 2002 to 2006, multiple transfemoral nerve blocks at L5-S1 on run, temporary pain relief. This was an L5-S1 internal disc derangement with more of the tears extending to the right side. 2011 to lumbar epidural blocks every 3 to 4 months for pain relief. 2016, further decompressive surgery at L1-2, remained disabled with partial pain relief. This is what happened. He was coming to me for pain control. I told him he had foraminal stenosis at L5-S1 on the right. He went to the surgeon who he said, I have to make a diagnosis. So he got another MRI scan. Didn't examine the patient. He did a foraminotomy at L2-3, no pain relief. Then he came back to me and said, I'm no better. Then we turned him, but then I went specific and said, it's at L5S1. So he had another surgery. This is what happens when you don't really pay attention to the patient. Remains disabled with with partial pain relief. Now, 2016 to 2023, remains with chronic low back pain with intermittent leg rating, primarily in the right side. Requires intermittent caudal epidural blocks to minimize low back and leg pain. Also requires thoracolumbar facet joint area injections to reduce pain from scar tissue. Now, today, when you see a problem like this, there's no use to be critical. You want to know what happened. You want to know why it happened. And you want to then be able to look at patients when they come with a similar problem, possibly. Then you can begin to think how to treat the patient simply and most effectively. And this is what all of you should strive for. I think you're all, I'm talking to the choir, I think so. But I get incensed for this because I see this so frequently. I'm trying. Now, this is very interesting. I work with a fellow who does endoscopic surgery. 64-year-old woman with major complaint of left low back pain and pain radiating down the left leg into the posterior thigh and calf. Already you are alert. Already you are alert to the problem. Now, she was involved in a motor vehicle accident 18 months prior to this evaluation with no prior history of low back or leg pain. She was in her motor home and was T-boned by another vehicle going about 50 miles per hour. She was thrown from the seat. The motor home was totaled. Her major complaint was left low back pain as well as posterior thigh and leg pain. She had no foot or heel pain. Pain became persistent and affected her ability to hike, participate in aerobics, drive, etc. Look at the treatments: physical therapy, chiropractic, TENS unit, massage therapy, acupuncture, nerve blocks, epidurals, pain clinic without significant relief. All of these treatments are good for the right patient. When you see this history coming and you know about internal disc disruption, your mind starts to think. On the internet, she saw 6 specialists, 3 surgeons, none of them could account for her back or leg pain, and no diagnosis was made. Only non-surgical conservative treatments were recommended. So now you have a 64-year-old lady and say you have to live with pain and you don't really know what the problem is? Wait a second. You stop and think. On the internet, well, here, we'll go to the MRI. This was her MRI, L4-5. She's 64, 4-5. Didn't look bad, did it? Now, there was some degeneration at L4-5. But let's say that happens. But now you look at this. There's a high intensity zone. Many doctors say high intensity zones may or may not be the cause of pain. You don't know. But when you see that, you see a patient who has a classical findings of internal disc disruption, you look at the horizontal view, a grade 4 annular tear, concordantly painful. This is what was removed from the disc. Just that, again, a nuclear fragment that has been separated from the major part of the nucleus, and the nucleus pulposus cells are now dying, called senescent cells. Now, underwent endoscopic surgery at L4-5. Nuclear material was stained blue, was removed from the disc, and then pain relief was immediate. Pain was able to stand erect from a forward bent position. 2 months later, patient stated she was pain-free. Pain has not recurred. Wait a second. That tells you a lot. It tells you not everybody responds this well. You have to do other things sometimes. But you've got to have in your mind internal disc disruption as a possibility. Now here, look at this. Low back pain, repetitive forward bending and lifting over 30 years. She sold carpet samples and bent over her trunk 30 years doing that. She has suffered low back pain for nearly 30 years. Pain was becoming progressively worse. Sitting and most activities became increasingly limited. Saw several doctors. They looked at her and I said, you just have degenerative disc disease. She even had Regenix therapy. Well, I don't know exactly what that is, but something in the disc. Recent clinical evaluation revealed the probability of internal disc disruption. She was my patient then. Now look at this. If you are in a clinic and you're seeing people quickly, you see this, I don't see anything wrong with you. Why you have pain, I don't know. Now let's go back one. Now look at this. This is the CT. This shows a picture of generalized annular degeneration because of nuclear fragments causing pain. Now look at this. This was what was removed. Now, patient underwent endoscopic surgery. Degenerative nuclear material was present for up to 30 years, the primary cause of her low back pain. After 2 months, she had virtually no low back pain. I can now sit in meetings, watch TV, sit in a car without squirming, getting up and going for a walk or lying down. Now, after several months, the low back pain partially recurred. Not the severe deep pain of IDD, rather an aggravating pain consistent with degenerative disc disease. The discs were collapsing and were becoming mobile at that time, causing stress on the sensory nerves within the annulus. After about 1 year, a patient's low back was essentially pain-free, and she's fully active today. There's no recurrence of pain. Wait a second. How many people like this are walking around that are suffering? This is a 20-year-old boy. Had a 2-year history of back pain without significant radicular symptoms. He suffered no specific back injury, but played many sports, especially basketball. He is 6'3", weighs 185 pounds. He consulted many physicians and spine surgeons in the Indiana area about his low back pain. There was a posterior disc bulge at L4-5. It was not considered to be the cause of the patient's pain. At that time, the pain was considered to be nonspecific. He went to Kansas for consideration of prolotherapy. The physician referred him to Tony Mork. Now, remember, disc bulges are not necessarily painful. But if you see a disc bulge and it's clear-cut internal disc disruption by clinical examination, put the two together. No one did. You see the bulge here, they didn't, because he had no leg symptoms, but it was low back symptoms. That's what got him. And look, L5S1 didn't look bad. Now look at the CT discogram. L4-5, you saw nuclear material extending into the disc. But L5S1 had a major tear. And look here. I want you all to see this. This is a fragment in the spinal canal between the posterior longitudinal ligament and the body of the disc. Wait a second. You can't take that out at surgery. And you see the other pictures here, and look how bad that was. this was the nuclear material removed. Now, this was interesting because after endoscopy, patient remained painful for nearly 9 months. Gradually, the low back pain subsided. He is now pain-free. Why? There was still a fragment within the spinal canal. They could not remove that. They did not know, but they were hoping that that would resolve. It did. Took 1 year before long was entrapment of painful nuclear material. This is a 43-year-old girl. She was very active. Rear end autocclusion, severe left low back, buttock, and thigh pain. Received chiropractic treatment for about 1 month, no improvement. Was diagnosed with soft tissue injuries of the low back. Received prolotherapy for about 11 months, no improvement. The physician tried. What was he lacking? The ability to make a thorough diagnosis. This is why all of you, even though you're accomplished in what you do, always look further and take each patient as a lesson on how to do things better. Well, so this is what you saw here. You saw a disc bulge, but the nerve root was above it. So she shouldn't have pain. This was a surgery, just as this is endoscopic surgery. And it's amazing what you can do. What's amazing what you, this was removed. L45. Median of a certain patient low back pain went from 8 of 10 to 2 or 3 level. Further lumbosacral prolotherapy allowed the patient to become pain-free. Low back pain has not recurred. In comes a mother with her 16-year-old daughter. Since age 12, she was playing softball, and she was a good player and was hitting the ball all the time. But from 12 to 16, the connective tissue is weak because the child is growing. She was referred for prolotherapy treatment with a diagnosis of right sacroiliac joint disarrangement of the lumbar spine. She has been experiencing low back since age 12 when she started playing softball, having many falls while snowboarding. Swinging the bat became quite painful. She was no longer able to play softball because of low back pain. She has undergone many medical evaluations. No specific diagnosis was made. None was made on this girl. Clinical examination revealed, this is when we saw her, it was obvious. You didn't have to look at her for a half an hour. You knew exactly the problem. Now, show you what she went through. And no one sat down to say, what is going on? Lumbar x-rays, negative. MRI, negative. Bone scan, negative. Blood test, questionably positive ANA. Steroid treatment, no reduction in pain. Chiropractic care, 3 months, no improvement. Laser light therapy, no help. Acupuncture, no help. Then went to UCI. On December 2, left lumbar radiofrequency ablations, L2, 3, 4, 5, no improvement. On July of 2020, right lumbar radiofrequency ablation, no improvement. November 2020, right sacroiliac joint steroid injection, no improvement. What? No one could figure that one out. No one. She came for prolotherapy for me, but this is not a prolotherapy issue. This is very mild, but there's a tear in the posterior annulus at L5S1. And you see a breakdown here, but it's very subtle. Unless you could relate this to the patient, you would not have known. The scan was interpreted as normal, but based on clinical findings, the probability of ID was very high at L5S1. Now, I want to show you what can be done. Here you have a 16-year-old girl, and you're going to recommend to the parents CT, discography, and surgery? No. You're going to base your treatment on her youth and hopefully ability to heal. Patient was unable to squat past 45 degrees without increased low back pain, was unable to bend forward, brush teeth, and load dishwasher. She's telling us what is wrong with her clinically. She's telling us. No one paid attention. No. Treatment, no softball, careful exercise, just enough to stimulate perfusion through the vertebral end plates. You don't do anything vigorous, very light. Anti-inflammatory diet. We follow the diet of Barry Sears. Increase protein between 50 and 75 grams per day. Take omega-3 fatty acids and polyphenols to reduce inflammation. If the patient is to recover, I expected 12 to 18 months. Ideal, inject disc with an anti-inflammatory, but we didn't do that. After 8 months, only mild low back pain, gradual improvement is present. At 1 year, pain-free. 1 year pain-free, young girl, and she was healthy, and all we had to do was monitor her program. I thought it would be 18 months, but when it was a year, I was very happy. Now, I want to show you something. But what you see here is just amazing. This is a patient I have followed for over 20 years. There are many reasons why we couldn't do the treatments that we should have done. But this man was in the military. He's a big fellow. He was 6'4", 240 pounds. He injured his low back while in the military, and he had a laminectomy at L5-S1. Fine. He left the military because his wife was ill at 12 years, after 12 years. But then he got a job with a youth department in Santa Barbara, California. One day he had to subdue a rather large boy who was wild. He grabbed him and he was twisting him back and forth, back and forth. Severe low back and right leg pain, severe. He went to a surgeon, MRI, no disc herniation, none. You have to have a disc herniation to have leg pain. No, you don't. You do not. Then he was referred for prolotherapy. 1 or 2 treatments were done, and we said, this is not going to help you. This is not going to work. Then we started doing caudal epidural blocks. That worked. It lasted for 6 months. Then we said, this is not going to work because the right leg pain was very neuropathic. It was consistent with dorsal root ganglion dysfunction on the right side, L5, sacral 1. He went to Rick Derby in San Francisco, and he did, what do you call it, spinal kind of nerve ablations he did. Yeah, God, I'm trying to think of it, but I'll tell you. Then, every 6 months, for nearly 15 years, he would go. He would always have a breakdown if he did something excessive. So he would come to me for a caudal epidural block. I said, you can't do this. It was in workers' compensation. It was in his work, so nothing happened. Finally, he retired. Finally, he said, I'm ready. Now, this was, and well, after we had seen him, we told the doctor it's at least L5-S1. So we did the Charité 3. This was early on. And did that help him? No. Wait a second. It didn't help. There has to be a reason. The neuropathic pain was still there. Now, this goes in, this just goes into his history. U.S. Army for 12 years, but I'll go back and call. I won't go. Now, finally, we were able to do a CT discogram at L3-4. Concordant low back and leg pain at L3-4 and L4-5. Now, this is not a typical. But this shows you, this is a degenerative pattern. And the concordancy of the injection told us that this was his problem. This is what was removed, nuclear material. That's all. His leg pain diminished by 60% within a matter of a couple of weeks. The mid-back pain that he had been suffering quelled nearly immediately. The problem here is that the discs, only have a very small margin of annulus. So you would expect a certain amount of weakness there. But at this point, he's virtually pain-free. Now remember, he had pain for over 20 years. He was on high doses of narcotics and a multitude of medications. And he ate these pills just like candy. He's off of them all now. This was diagnosis, diagnosis, diagnosis. The reason I want to show these to you is I want to show you the real life, what does happen. So let's say it's due to generalistic ECS. No. I want to show you this. This is very recent. Very recent. And this is a travesty. Travesty. It never should have happened. Young man in his 30s was water skiing. He was traveling about 70 miles an hour and fell on the water. He suffered low back pain. X-ray showed no overpathology, was unable to work thereafter. I saw him when he was 59 or so, was provided opioids for pain control, was reevaluated when he was 59, the clinical internal disc disruption at 3 levels. Now, he's on disability, et cetera, and it was clear cut what this problem was. And traumatic inflammation of the lower lumbar spinal canal and chronic sacroiliac sprain. Those were secondary. Because pain was impatient, underwent lumbar. We told him what the problem was. Well, he didn't have the money for CT discography, et cetera. So I want you to look here. L5S1, L45. These discs are not bad, are they? Obviously, internal disc disruption, because that was a clinical exam. I want to show you what they did. He had an acute access of pain. Went to a surgeon, and he saw that he had mid-back pain up to T9. But I promise you, and never forget this, when you have internal disc disruption at L3, 4, 4, 5 down, and the pain is persistent, the pain radiates upward. And then you don't know if you're dealing with thoracic spinal pain or you're dealing with lumbar pain. He was fused from thoracic 9, including the sacroiliac joint. The physician then said, if you have pain, you need to go to pain management. He had pain. He came back to our office and asked if we could help him. They looked at that and said, no, nothing we can do with prolotherapy. There were ways to treat him, but we couldn't do it. But so here's a man who's now in his 60s. He'll be totally disabled for life, and he never needed surgery at all. I want you to look at this. Just so, no, this is February 20th, Vincent Heck, University of Cologne, Germany. Predict that the use of posterior spinal fusion will increase to 102 procedures per 100,000 residents by 2060, an increase of about 83% compared to the years 2005 to 2019. Demand will be even greater among older patients who often need more costly care and so placing an enormous strain on healthcare. Comment, treatment of spinal dysfunction causing, in most cases should be with an interdistal containing growth factors and a connective tissue solution, also containing growth for sacroiliac, facet joint, and so forth. This is the mindset of a lot of doctors, of a lot of people. Oh, we have a lot of older people here. Oh, you have back pain, you need a spinal fusion. Oh. Well, I wanted to show you these patients. I want to show you what can be done, and I want to reinforce in your mind the concept of internal disc disruption and low back pain. I hope this is of value. We can go over to a few other things now. Do you want a break now? What? Okay, time for a break. 10 minutes, 15, what would you like? What?
Schedule 30, but
30 minutes?
you feel okay?
I'm fine, I can go. Okay, 15-minute break,
30.
13-minute break. Okay, everybody gets a break.
If any question? Before the break, I will take some question.
Thank you, doctor. It's very amazing presentation. In case I just want to ask, can we inject the annulus without ultrasound because it's deeper, I think, and it's difficult.
Say, yes, yes, oh yeah. Inject the disc.
Yes,
Yeah.
because I think and your presentation is very important to treat the annulus. Thank you.
By, yeah.
Can you inject annulus without ultrasound or fluoroscopy? What is your experience? Because I think you made that annulus is very important, right? Annulus of the disc is very important. How you treat it with ultrasound or without? Thank you.
You're asking me about treating the annulus of an intervertebral disc. Now, if you see radiographically degeneration, if it's not painful, you're not going to treat it. If it is painful, you have to make a decision whether that pain is due to instability of that motion segment versus internal disruption of the disc with what you saw here. If it is basically unstable, I'll tell you the now and the future. If it's basically unstable, the first thing is to treat all the structures around the disc, not the disc itself, because that's hard to do. And you treat that first. Now, in the future, it's not here yet, but you could certainly add growth factors to the center of the disc if the disc is not too narrowed. If it's more than 50, 60, 70%, there are not enough cells in there that you're going to do anything. I've had patients that have narrow discs. We have treated prolotherapy and waited for time to allow the disc to settle. In the future, you certainly can try various solutions that could aid in fibrosis within a disc that's narrowed to provide stability. And that is coming. That is coming. My attitude is always do simple first. Don't always look for generalized stability and make sure there's no inflammation within the spinal canal. Do those simple things. Make sure that the facet joints of a narrow disc at L5S1 are not contributing to the pain, because that can be treated directly. That's what I would do. Any other questions? No, break time. Oh,
Thank you. You said do the simple first, but how many times before you do the injection of the disc?
How many times?
Of course, we not do the simple first, and then we do it. How many times we
Would
could
you
do it
inject
before
it?
we go into the disc?
Good question. Some people will say that by placing a needle into the disc will cause disc degeneration. If the needle is large, yes. In the work that I have done with other people, a 25 gauge needle has been universally used to penetrate the disc. Now, is there a way of treating the disc? You're saying how many treatments could you do? Is that correct? Let me go back in time. Circa 2000, with Richard Derby, who was a spinal interventionist in San Francisco, we treated about 43 patients, all with internal disc disruption by discography. We did not know at that time if we could help them or not. We injected the discs with dextrose, chondroitin sulfate, glucosamine hydrochloride, carboxymethylcellulose, and local anesthetic. The concept was that chondroitin, glucosamine, and I think in hyaluronic acid would serve as a bedrock to rebuild tissue. Our concept, we didn't know what was going to happen. So when they came back at 3 months, would they be better? If they were better, we would do a second treatment. And all of the patients voluntarily wanted a second treatment if they knew they were getting better. Everyone. Now, what happened? Everybody was treated 2 to 4 times. Look what we use. We use something simple. Something very simple. It worked. But it wasn't they could do one treatment and say you'll be well and something. We were guessing. We didn't know. But at 1 year, every single patient was more than 50% better, and some were 80%, and a couple were pain-free. All we could say is, wow. Then you would have to go in to do it for FDA, you'd have to do a clinical trial, and then you have to have millions of dollars to do that. So that ended that. But yes, you can inject a disc. I don't know about ultrasound because I know this is very popular, but I don't know if fluoroscopy works very well. But in the future, when you see patients with internal disc disruption, whether you do it or not, you will manage that patient to get a CT discogram. You will manage the patient to be injected properly. But you also are going to strengthen all the tissues around the ligaments and muscles to provide dynamic and passive stability to the segments that you are treating. Then nutrition, exercise, then you're going to have a winner. That's the way it's going to be in the future. And all of you will see this hopefully in the not too distant future. Any other questions? Oh, one more question.
No, final question.
Thank you, doctor. I would like to ask, what are the clinical findings on when, for example, the patient's pain referral pattern or physical exam findings that can raise the suspicion of that we think the patient has a IDD before we arrange the CT discography for the patient?
What are the clinical findings?
Yes.
I would like to show this to you, what I do. The first is history. Look for the injury, and then look to see the response of the patient in the period of recovery. Does he get better? Or does he find that he has to limit his activities by sitting, by playing sport, by bending forward, by lifting? That's the first thing you look at. Then you ask, when he comes to you, you not only look at central pain, you see if there's a referred pain pattern. I will go over that. It's in your handout. You look for referred pain. Referred pain patterns tells you very clearly what levels you have to look at. Now you know that. Then if you want, then the clinical examination should tell you. There are things that you look for, especially if there's leg pain. As in the physical exam, I've had many patients who come to me with severe medial thigh pain, and it's hypersensitive. Every time that we've evaluated them, it's internal disruption at L5S1, every time. When it's groin pain like this, every time that I've seen, it's L4-5 disc, L4-5 disc, L3-4 disc. The history is very important. Then you do straight leg raising. You're not looking for nerve root compression. You're seeing how high the knee goes compared to the other side. You then palpate the sciatic nerve. You palpate the hamstring muscles. Medial hamstring L5, lateral hamstring S1. Then they lie face down. You place your finger over the midpoint of the sacrotuberous ligament in the buttock. If that's tender, you will know it with your hand. That's tender. You say, you compare. Then you go up to the S1 posterior sacral foramen. You palpate each side. And you have to do it a few times. There's a discogenic issue here. Then you go to the space between the L5 spinous process and the sacrum in the interlaminar space. If that's very tender, it's telling you. Then next you palpate one side versus the other of the L3, L4, and L5 spinous processes. If they're very tender on one side, you know that's the medial branch of that nerve. Now, this is not 100%, then compression. Compressive tenderness between the motion segments, so that's very tender. It's not 100%, but once you become accustomed to looking for this, you'll see nuances that you will understand because of your experience. Then you'll be able to pick out these problems very clearly. I've done this for many years. I just have a sense or a feel for it. But everybody can get started and have trust in your hand. Palpate. Feel the tenderness. Is this neuropathic tenderness? Is this mechanical tenderness? And I would tell you, is this discogenic tenderness? You all can do it, but you have to have experience. You have to see, you test and you see what happens. And all of a sudden, your hand is the best tool that you have besides this. Most of this can be done by good examination, listening to history, and relying on your senses. And if you're unsure, sit back. Maybe observing the patient and just sit back and get a feel of that patient. You'll find the answer. That's all I can say. How are we? Okay? See you in 13 minutes.
Okay, thank you for Dr. X's great speech. So we take a break. I think we will not take 30 minutes. We take just 20. Okay, so come at 3:30.
think let's just try to downside say the next slide the topic is the PJ fire can be stopped. I don't know why. So we just outline. This one. Yeah, this one.
The first one, well, I didn't do any of them. He has somebody that actually worked on it. So I can't help you. It was, I think, the way she put it in the USB.
Okay. No problem. No problem.
Yeah.
No problem. No problem. No problem. Everyone, so we have desserts outside the conference, and we have tea, we have cake, with fruits, we have coffee. So you are very welcome to enjoy. Okay, and we come back 3:30, and the bathroom is outside, down to the corridor, so you can just walk there, just see the toilet sign.
It can't compute it that.
Told this last week.
Oh, God. Okay, yeah. That monkey has back.
所以所以哎那个是要俊什么？我写俊宏对，sorry。我们测试一下这颗喇叭的声音，可不可以帮我再小声一点，就不会去干扰到那个口译官在口译的输入。那个好像应该都是整组设定好的，应该是一个基座设定好的。1点半。嗯，看能不能小声一点点，就不会干扰到他们的声音。123123123，好像好一点，有蛮小声的，这样感觉回音反而还比较大声，但是没关系，你们这样觉得可以吗？这样他有办法专注吗？听得到他老师我这样讲话讲，就是一直要提醒他啦。对啊。
只听下面的2个喇叭上来，声音会不会太？我刚才讲了，他说。
123，就真的蛮小声的，而且我现在在这边讲话哦，我现在在这里，感觉是真的蛮小声的，对不对？这样还听得到吗？清楚吗？
应该是说下面的量应该会比刚刚好。对，因为从这边进去的一定会高。可是我是怕，如果这样子传过来的话，怕有一些字母会有一些咬字的部分，就有可能会有。还是讲说我们等一下。
那你可以试看看，然后你有问题，你跟我讲，我讯息我赶快调。
我觉得还是那个。
这边先关掉，这样吗？是吗？好，那如果你真的觉得现场真的听不太到，你再跟我说，赶快跟我说，我再请他来开这样子。打开就好了。
切过去而已，
好。
左右切这样子。对。 喂，用传统的方式吧。没有，可以用到那我们现在把它调整中。要跟他讲，因为他要用什么东西用。可以的，没问题。对。Okay, everybody back? So, next topic will be the solution of orthopedic medicine, and then go to the physical nation, then go to the hip. Yeah, so hope we can have time to do some demonstration. Okay.还是先用一台，因为时间已经到了，已经40分好了。对啊，已经40分了。对。Okay, are you ready, Coco? 可以吗？可以开始了吗？Okay, okay. It's okay now. Okay, so let's welcome Dr. Bjorn Eck again. Okay.
Hello? Oh, okay. This is from my practice. I see patients 3 times a week. Now that I'm older, I see 6 to 8 patients only. But I spend at least an hour with each patient. The one thing that I've learned is that when you first see a patient, you make a thorough examination. You put down your findings. Oftentimes, the patient will come back and the complaints will be a little bit different. Re-examine if you have the time and the ability. You will find that by repeat examinations, you will find out just about exactly what is wrong with the person. And it'll pay you in dividends. The other thing that you want to do, you want to make your hand an extension of your brain. Everybody has energy in the hand. Some recognize it, some don't. But the hand will tell you oftentimes where the area of pathology is. But it's something that you have to practice with each patient. Might take a few years, but if you continue, you will find that out. Now, solutions. I don't know if this works. We'll see if this works. Oh. Solutions for, oh, thank you. Thank you. Oh, good. Prolotherapy, neurotherapy, trigger point injections, and caudal epidural blocks. This is basically what I do in my practice. It varies according to the area that I'm treating. These are the solutions that I use. 50% dextrose, 0.5% lidocaine, 1/4 or 0.5% bupivacaine, ropivacaine. I don't use that very much because I'm so accustomed to bupivacaine, but some people say that bupivacaine is not good, but I've never found that to be the case. Sterile water, normal saline, glycerin, Kenalog 10, DMSO, and ozone. This is what I have in my office. It's not a lot, but it's what I do. Now, when you make a decision about what strength of solution, if the patient is very hypersensitive, go slowly. Find out what the patient can tolerate. In my practice, I use 10% dextrose, sometimes 15, sometimes 20, occasionally 25%. I mix it usually with 0.5% lidocaine and sterile water. Occasionally, I will add DMSO if there is a lot of fibrosis, but people don't like it because the patient doesn't understand it, but it comes out on their breath, and that they don't like. Occasionally, we'll add Kenalog 10. Now, can substitute ropivacaine for bupivacaine? Yes. Now, this is basically, I'll go to my common solution, 20%, 4 cc's of dextrose, 4 cc's of lidocaine, 1 cc of sterile, and bupivacaine. Now, if I want to make it stronger, I will add glycerin. Let's say 15% dextrose, 10% glycerin, lidocaine, sterile water. The glycerin really does help. That used to be part of P2G that people used in prolotherapy many years ago. Couldn't get P2G. You couldn't get it anywhere, but you could get glycerin, and you don't need the phenol part of it. Here I'm trying. Neurotherapy I have found is very helpful in your treatment. In a 10 cc syringe, I use 5% dextrose, 0.5% lidocaine, bupivacaine, and Kenalog 10. I inject subcutaneously with a 30 gauge half-inch needle or a 30 gauge 1 inch. And I look for tender muscle bundles. And it's in the shoulder, it's part and parcel of my treatment now, and I've been very happy with it. You can use the same thing for trigger points and can use neural therapies for same as the neural therapy solution. Caudal epidural blocks. Caudals are very helpful both diagnostically and therapeutically. I told you about one of the issues that you see, but you've got to recognize it. If there is hypermobility, L4-5, L5-S1, because of posture, because of activity level, and then they do excessive bending or flexing, they stretch the dura. And you can get inflammation peridurally. You don't necessarily get buttock or leg pain. You get back pain, but it doesn't fit the standard. And if you identify it once, you'll never forget it again. And what you do is a caudal epidural block. Caudal epidural block can be done in a multitude of ways, but I'll show you the way that I do it because I feel satisfied with the results. Standard caudal, I use 1 cc of 50% dextrose, 8 cc's of lidocaine, and up to 1 cc of Kenalog 10. Sometimes you don't want to use Kenalog 10, so I do the caudal with 50% dextrose and 0.5% lidocaine. Some people feel that all you need to do is sterile water and so forth. My concept is that the local anesthetic will help the sensory nerves within the canal and will help repolarize them. So this is what I use. And caudal epidural blocks can be extremely helpful, especially if you know there's a component of dural irritability. You identify that by the clinical examination. You don't do it with everybody, but you do it when you think it is necessary. So here you have caudal epidural blocks, you have neural therapy, trigger point injections, and prolotherapy. People use PRP. That's okay, but the trouble is it's expensive and you need a lot of equipment for that. I have not found that to be necessary in my practice, and I treat many patients on a regular basis. Now, oh, good, let's go back. Now, these are just the bottles, so you can see what I get. 50% dextrose, 50% glycerin in a 100 ml bottle, 0.5% lidocaine, 0.25% marcaine, ropivacaine, sterile water, sodium chloride, Kenalog 10. Next. Occasionally, I'll use cyanocobalamin, and some people wish it. I'm not sure what it does, but if they wish it, I'm ready. DMSO can come in 2 different bottles. I use that very rarely, but I do. I use ethyl chloride spray on a regular basis. People prefer that. Next. Now, this is my little, in my office, this is where I mix everything. In America, people like sedation. So I've used sedation since the 1980s, and we use Demerol or meperidine, 25, 50, or 100 milligrams. We mix it with midazolam or Versed, just about half a C less, or 1.1, 0.2 cc's. This is fine. If we are going to do a caudal epidural block, I want 2% chlorhexidine because it's sterile. And that's the best chance you don't want an infection at all. And never, remember this, never do a caudal epidural block if the patient is recovering from a virus or a cold. You have him come back in 2 weeks. Never do that. They'll tell, and why? If you use corticosteroid, as an example, you reduce the immune system and they still have virus, they can come up with any number of inflammatory conditions. You never do it. So you always ask, if you're thinking caudal, or have you been healthy? Have you had cold for the last 2 weeks? These are the basic needles that I use. 25 gauge, 1.5 or 1 1/4, 25 gauge, 1.5, 25 gauge 2, 27 gauge, 1 1/4, 30 gauge, 1/2, 30 gauge, 1 inch. This is fine for nearly everything. Oh, I'm sorry. This is fine for nearly everything. 18 gauge, that's to draw fluid. 18 gauge, 1.5, that's good for for aspirating the knee joint. I'm going to show you a story which I didn't think was possible with ozone. The fellow I work with is a former Olympian. He was in jiu-jitsu or judo. Because of that, he has 2 total knee replacements. And one day, one of his knees became very swollen. I said, "You have a problem." He wanted me to aspirate it. I did 90 cc's of murky fluid. I said, "This is infection." I said, I gave him a sample. "You better take this and get this cultured. You need something. And you should see your surgeon because you might have to have the knee joint open and drained." Well, he didn't do that. Okay, he asked me for an antibiotic, which I certainly gave him. After I aspirated a knee joint, I injected it with 20 cc's of ozone. And ozone is bactericidal. It is, it's very good. And it's good for, it's antiviral as well. He didn't say anything, but he never went to the surgeon, and I didn't ask. 2 weeks later, he came back and asked me to aspirate the knee again. I took out 60 cc's, down from 30, down from 90. More ozone. 3 weeks later, I took out 20 cc's, more ozone. On an antibiotic doing it this time. His knee went back to normal. So the question comes this. Ozone, they say, is very helpful in treating joints and connective tissues. And if you have that available to you, you have to have oxygen, a special machine, which we have. That's a good helpmate. I like to use it when I'm injecting a knee, shoulder, or hip because I know I'm protected, at least to a degree, from any bacterial infection. Fortunately, I've never had a bacterial infection, so that I'm happy with. Next. Well, of course, the 22 gauge needle that is commonplace for me. I use that in lumbosacral prolotherapy. Now, if I have a thin, slender woman, I'll just use a 2-inch needle. Otherwise, I'll use the 3-inch 22 gauge. When I have a person who's not slender, I inject the ischial tuberosity on a regular basis today. And the 22 gauge needle works very well. It's solid, it doesn't bend. So I will say thank you. I've learned in my life to be simple. I don't try to do things in a complicated way. For all my career, thank you. I've sufficed with just this, and I've had satisfied patients. I had patients who returned to me. Well, I had one fellow who flew in from Kenya, Africa, just to see me for his back. I don't know why, but at least I sorted it out for him because he was afraid to have surgery. He didn't require it. This is something very interesting. I'll give you this story. It'll make you think again. This is a man 70. He's a missionary in Kenya. I treated him years ago. Originally, he was very athletic. He had laminectomies done at L4-5, L5S1. That solved the problem temporarily. Then he got severe back pain again. He came back, and this was discogenic pain. You knew it. You very tender centrally, and you looked, the discs were crumbling. We injected the discs with dextrose, glucosamine, chondroitin, and a local anesthetic and carboxymethylcellulose. We did it about 3 times over a period of a year. All of his low back pain subsided. Now, that works. Growth factors that we're hoping for will obviously work better. But there are ways to do things simply, and that's what we're trying to do now. Then he came back, and he had severe low back pain again. This is several years later. He came back, and he had spinal stenosis at lumbar 2-3. I said, you have to have that treated. I referred him to 2 surgeons, one orthopedic, one neuro. The orthopedic surgeon saw how bad his back looked. He wanted to fuse him from lumbar 1 to sacrum. The other doctor said, let's just decompress L2-3. He opted for the simple, and that solved his problem. Then recently, he over-exercises. And he recently came back. I have terrible back pain, he said. I was in Kenya, and they did 2 epidural blocks. Then I said, did they do it under fluoro? No, he did it blindly. Wait a second. That doesn't make sense to me. Epidural blocks, because they do it under, they had him sit. I didn't know how he did it, and I didn't know where the needle went. But then he said it only lasted for a week, and I was no better. What? Then he said, I got to come and see you. So he comes to California. He has severe pain over the left lumbar area here. Remember, he's right side dominant, but he has to do all these exercises going like this and up. And he was convinced he was going to have surgery. He not only went to me, but he went to other doctors, and they did nerve blocks. Thoracic 12L1 down to L5S1 bilaterally. Didn't help him at all. Oh, I'm going to have nerve ablations now. I said, what? I think this is stupid, I think. What was his problem? Here he has a lumbar spine that's fixed. It doesn't move, and he goes like this. What does he move? The sacroiliac joints like this. He bends over the quadratus lumborum. Now, the first time I saw him, I did an epidural because I didn't know. And the second time I said, when he came back telling me all the things that happened to him, let's examine you again. When you examine again, you don't just pick the pain spot, but examine the total back, because you might miss something. I did. His problem was injury to the interosseous ligaments between sacrum and ilium. And on this side, it was the quadratus lumborum muscle at the attachments to the 12th rib and the transverse processes. I said to myself, this is unique. You don't see this. You recognize it if you are paying attention. Every time you see a low back, in your mind, you go step by step in your mind. You don't have to write it down, but you look 1, 2, 3, 4, 5. It'll come to you. it will come to you. I urge all of you, when you look at a low back, a neck, you don't just look at, oh, it hurts here or there. You look at the total person and you see how they walk, how they move, etc. And then it tells you what's wrong. Then I urge you again to use your hand. Practice with your patients. You're looking at the shoulder, yes. Put your hand, see if you can feel heat. See if you can feel any abnormalities. If you do it long enough, you will. And I've been able to identify several problems. I was insecure, just putting my hand over the back and feeling for heat and energy. All of you can do this. Now, we go to the next one, which is the
Hi,
hear you.
hi. Could you repeat the contraindication of codo epidural in black? Because I
The
couldn't.
caudal epidural, what I use.
No. I think I hear that virus infection is contraindicated, right?
Yes.
Correct?
Well, let me tell you,
Right.
I've seen this before. A patient, give you an example. I saw this, I witnessed this patient. Came in because she had severe low back pain. She said she was fine, but 2 weeks before, she was suffering a severe flu syndrome, was in bed. I'm over it, she said. Are you sure? And we said, well, because you benefited by a epidural before we did it, we used a small amount of it, of corticosteroid. She left the office pain-free. Oh. Called up about that night and said, I have a severe headache. Uh-oh. You don't say, let's see you in the morning. I said, immediately go to the ER. You need to go now. She had meningitis. She still had a virus in her body, even though she said, I'm well. That was enough for me. Never again do an epidural when you're getting over a viral attack. Never do it. It's game-changing. And I will tell you another thing, not to me, but to another doctor that I know. He got careless. I showed you the bottles that I have on my table. When I fill a syringe, and I'm going to use that syringe and needle, never, and I will tell you, never go back with that syringe and refill it after you've used it on a patient. Never do that. There's a very good reason for it, and that is safety and your license. Why? This doctor got careless, and he thought he could save money by using the same syringe, you see. One patient one day came in and looked very healthy, but it had hepatitis C. He didn't know that. Never told him. But he went back, injected that patient, filled it up again, injected the patient. 3 more patients that day came down with hepatitis C. then all of a sudden in California, you have a medical legal problem, a real big medical legal problem. It was based upon saving money on syringes. Never use a syringe again when you inject a pain. You dump it. And this is for all of your safety sakes. You don't want to have a patient that you're treating, then they come down with something that you gave to them. And that is one thing you never do. The other thing is when you do epidurals, and you have to have a sense, if the patient doesn't look right to you, doesn't look right, that comes from your heart, not from here. Pay attention to your heart. Better be safe. Tell the patient to come back in a week or whatever.
Right.
In America, if you do things like that, you can lose your license. And what do you do then?
Mm.
And this fellow, he was reprimanded and he was sorry this happened, but they put so many, how do you say, provisions. He had to work under another doctor, couldn't do this, couldn't do that. So he had to retire. That's not the way. I'm telling you, two things. Never reuse a syringe on anybody. And two, if you to never do a caudal, especially with corticosteroid, if they've had a virus or they're getting over it, you'll save yourself by doing those little things. Now, palpation and markings, palpations and markings, physical examination. Now, this is my granddaughter, and we just decided to see if we could figure out where we were. This is rudimentary, but I wanted to be sure what I was doing, and I looked at it again. I said, "Well, this is not the way I'm going to do this." Now, this is Joel Baumgartner, and this is very good, and this is another A, B, C, D, etc. Here, 2A, 2B. Markings are fine, especially when you get into a heavy person you don't know and you're not sure about the anatomy. Do markings. Look again to be sure. But markings are done oftentimes mechanically. You just put a line here, a line here. Never do that. When you make a line over the iliac crest or the margin of the sacrum or L5S1, you think in your mind, what are you sorting out? Iliac crest, what muscles are there? What ligaments are there, etc. in your mind. Then markings become very good and helpful. I do not use markings for the majority of people, but when I see a person who's very overweight and so forth, it's a good idea to do that. Now, markings. First, when you look at a patient, think stability of the lower three lumbar segments in the sacroiliac joints. Here are the ligaments of below and the muscles above. Look at the person to see how fit they appear to you, how they move to you. Then palpate for tenderness with your hand. Now, a lot of tenderness doesn't mean that this is a site of pain, but if you find too much tenderness along the spinous process or iliac crests, and you look at the health of the person is not healthy. Be wary. You're looking at a person who is not really fit. And if you're going to treat, you treat with care and you go slowly until you can be assured of what is wrong. The anterior abdominal muscles, certainly. Anterior abdominal wall. you rarely do you have to inject those areas, but exercise is probably the best treatment of all. And muscles of the anterior thigh, the quadriceps muscles at the intertrochanteric line. Practice that because I don't think any of you have really paid attention to it. This can be a tremendous helpmate with anterior groin pain. And you can identify it clinically by examination if that's a problem or not. And hopefully we can have somebody come up and we can show how to do this. Next, always think posture, fitness, nutritional, hormonal, and systemic inflammation when you see a patient. It may not be important for the majority, but a lot of people will require help in these areas. What am I doing? I'm trying. I need help. Oh, there. Now, I want you all to look at this. I want you all to look at this. Thank you. When you're examining, and the questions that were brought up to me here, how do you identify internal disc disruption? First, the history. The patient has had a significant injury or repetitive stress. You ask have they had to curtail lifestyle activities such as playing sport or walking, doing whatever. They say, I can't do this, I can't do that. You begin to suspect internal disc disruption. Then you ask where they have pain. Remember this. Always remember this in your mind. When the person puts his hand on his buttock or his thigh or leg, I want you first you palpate with your hand. You feel a quality of tenderness that indicates referred pain versus local pain. This is something that all of you can do, but you practice every time you see a patient. All of you should go over this with a great deal of care. Now, next. Physical examination. These are just a few questions, but where do you have pain? Please point with your hand. You always ask them if they have low back pain as an example. You always have the patient carefully put his hand on where he or she hurts. If it's here, that's where I'm hamming. You think in terms of the dorsolateral fascia. If they go here, you think of discogenic. If you go here, you think of sacroiliac. So look where they put their hand and pay a lot of attention to that. And every time they come back, have them put their hand on their pain. If it changes, then you know they have other issues to deal with. How long have you had the pain? Is the pain intermittent or constant? Is the pain getting better, same, or worse? Does the pain travel to your buttock, leg, or foot? If you have IDD, now it's not always IDD. If you have it, you're going to have referral because the tears within the disc through the annulus are affecting the sensory nerves in the outer third of the annulus. Then what activities make the pain worse? So they tell you, I can't garden. If I went to have a chiropractic manipulation, I was worse. It's telling you what to look for. Are there any activities that you no longer do because of pain? You take your medications for them? Do you take for other reasons? Have you undergone any surgeries, etc.? Next. Now. Basically, this is what I do. Observation. You watch them walk. Is there a limp? Do they walk slowly? You watch them sit. Can they sit with both buttocks on the chair, or do they prefer to bring up one buttock? If you see that, they're like this, you know it's either severe sacroiliac pain or discogenic pain. You look to see the rapidity of movement, their affect. Physical examination. When I do it thoroughly, standing, sitting, lying supine, side lying, and prone. This is what I want to do. Next. This is a physician from Mexico, but he's a patient too. First of all, I look for standing. He complained of low back pain. Obviously, there's some more problems here. But in your mind, have a list and go down it. I've seen so many people, doctors, spending less than 5 minutes doing an examination on the back. What? And they were supposed to come up with a diagnosis? No way. Look in your mind. Lordosis, accentuated lordosis, increased stress upon the L5. That increases stress upon the L5S1 disc. Flattened lumbar spine, that's spondylolisthesis or osteoarthritis. Step off, spondylolisthesis. Obvious lateral pelvic tip, short leg syndrome. Forward lumbar tilt, spinal stenosis or disc injury. And you go in your mind doing that. If you do that on a regular basis, if you have a little sheet by it and you just check these off, that's a tremendous helpmate. I always want them to point where they hurt. And where they point tells you a lot, whether it goes on both sides or one side. Here he's talking about an upper sacroiliac problem. But no, so then point with a finger at tenderness while standing. Then you palpate yourself. What you want to do is feel the quality of tenderness. And if you do it long enough, you'll say it's mechanical tenderness, it's discogenic tenderness, or it's neuropathic. You'll do 1, 2, 3. And that, again, is a helpmate. It doesn't tell you what's wrong. Then tenderness during lumbosacral extension. If they have central low back pain at 5-1 or 4-5, you know where to focus. And always reassess the sites of tenderness while prone. This is basically what I do. I go slowly with this because I want to see if I provoke pain in any of these movements. And it often will tell you exactly what you have to look for. Now, when one complains of buttock or leg pain and they're not walking right, do assisted heel and toe walking. This is a very good test for the L4-5 and S1-2 disc. This is very helpful. Now, I do sitting, knee reflexes, ankle reflexes, sitting straight leg raising, rarely positive sitting. But if there's resistance, you want to find out where it is, particularly if it's in the buttock. Resisted thigh flexion, iliopsoas, L2, L3. Resisted thigh adduction, the adductor brevis, longus, and magnus, L3, 4. Resisted thigh abduction, gluteus medius and minimus and tensor fasciae latae, L4, 5. Resisted knee extension, quadriceps, L2, 3, 4. Resisted knee flexion, L5, S1. I'm not telling you what to do. When I examine a patient, I go through this and I tell them what I'm testing. Extension, I say L3, 4. Flexion, L5, S1. Why do I do it? I'm doing it to educate the patient and make the patient feel that I am interested in their problem. They're happy when I do that. Resisted ankle dorsiflexion, tibialis anterior muscle, L4. Resisted great toe dorsiflexion, extensor hallucis longus, L5. Resisted lateral toe dorsiflexion, extensor digitorum longus, L5. When you do that in your mind, you always think of the muscle that you're testing. Why? It's easy to forget the muscles. I've seen doctors that really don't know because they haven't been, how do you say, testing themselves with each patient. Resisted ankle dorsiflexion, plantar flexion, gastrocnemius, and soleus, S1, S2, and you go down the line. This is very helpful. While sitting, sensation to touch, medial thigh. If they're very tender here and it's hypersensitive, you don't have to ask any questions. You look at the L5-S1 disc first to pick up the S1 and S2 nerve roots. Lateral thigh and buttock, L5 nerve root, anterior thigh, L3 disc, etc. Tremendous helpmate. Tremendous helpmate. While supine, patellar clonus, ankle clonus, plantar responses, ability to do a sit-up. It might be because of pain, but the patient will tell you. If not, if they can do it, abdomen is strong. If they can't, abdomen is weak. Then you go, ability to elevate the legs to 30 degrees. They're lying supine. They bring up 20 degrees. If you can push it down, and they tell you they have pain in the groin, the quadriceps muscle at the intertrochanteric line, you know it. It tells you what to look for. And if you see that, then you know there's a problem with the iliofemoral ligament. Knee assessment. When you're looking in the back, you go through it quickly. The first thing I will tell you, you can pick up an awful lot of things by just looking. You'll identify effusion, but it's not just effusion. You're looking for any soft tissue swelling, medial knee, lateral knee, over the patella. And you know when you look at it instinctively, it's not an effusion, but it's a reaction to injury of a connective tissue deep to that area of swelling. Now, you always check for overextension of the knee. You compare both. If you see one knee that has lost that hyperextension and blocks, you don't have to ask, but you better look at the posterior knee joint. It can be a number of injuries there, but that they might say that's my problem. And then they tell you I have anterior knee pain. But if that's a problem, you look posteriorly first because that pain is usually referred. Varus and valgus. People who have very varus knees, you know they're going to have medial meniscus problems later on in life. Ankle and foot, simple, bunion, varus hypermobility. Plantar fasciitis, tenderness of the sinus tarsi, tarsometatarsal junction, and intermetatarsal spaces. This is a tremendous helpmate and you can do all of this in a matter of a few minutes. It doesn't take an hour to do this. Pile supine, straight leg raising. It varies whether if you see a very athletic man or a very unfit person, straight leg raising is limited. You compare both, and you always put in your mind the dominant side, right side dominant, left side dominant. Then what you do with straight leg raising, nearly always you're looking for sciatica. And when I was a student, you look to see if there's no pain going down into the thigh, that means you have a disc herniation. Agreed. You rarely see that. Rarely see it. But if you find resistance and you get a block, in your mind, you close your eyes and feel. When you do that, and you will identify it. If it's in the buttock, what do you look at first? The hamstring muscle attachments to the ischial tuberosity. From there, you look at the sacrotuberous ligament as you go up. These are little things, I'm not telling you what to do. I'm just telling you what I do. Now, straight leg raising. The bowstring sign is very helpful. You test the sciatic nerve, the medial hamstring, and the lateral hamstring muscles. You start at the knee level, the popliteal fossa level. You may go up the entire sciatic nerve. Nothing. You get just below the gluteal crease and they're tender. It may mean nothing, but be alert. There's irritation, there's likely irritation to the sciatic nerve. You go very carefully over the lateral hamstrings. Remember, there's a lateral head attached to the lateral lip of the linea aspera, as well as the long head. Then you do the medial side. And you might just get tenderness proximally. And you test both sides. This is just one finding. It doesn't mean that it's everything. But uh-oh, there's tenderness. We have to see if that means something. Now, then I go to the hip extension. Now, we'll talk about the hip next. And I want to show you this. The first thing you do when you see a patient lying supine, when you look to see if the back, you rotate the leg. Just rotate. What you're doing, you're feeling end motion. Usually internal rotation. If there's a problem with the hip, you're going to feel it. They might not tell you it's painful, but you'll feel it, so you know what to look for. Then you flex to 90 degrees. You externally rotate, you internally rotate. If you cannot, you cannot rotate externally very much or internally, you know this is an arthritic hip. It's sine qua non arthritic hip until proven otherwise. Then you do at 90 degrees, you do external to internal flexion. Then you do flexion to the abdomen. This, I'm telling you, is very important. It's based upon how it feels. You don't go quickly and go, oh, there's not a problem. You do that, you'll miss it. You slowly bring the thigh to the abdomen. You know, to the abdomen. You feel you're gonna, uh-oh, there's a problem here. Iliofemoral ligament, rectus femoris muscle, joint capsule, etc. It tells you. You don't know what it is, but it tells you you've got to look further. Yeah, I'm sorry, you got to look further. I'm sorry. Yeah. So hip, then the hip, we're going to talk about that next. But the hip, for many people, is a very difficult joint to evaluate. It was for me. I didn't know how doctors figured it out. Now I can share with you, you can figure it out and I'll show you how. And why it is so important. Why? Now, let's see what else we do here. Now, while sidelying, I do the Don Tigny maneuver, the glute. He's a physiatrist. I don't know if he's still alive, but this was to test the sacroiliac joint. And for me, it has worked very well. And when I'm done with this, I'll ask somebody to come up and I'll show how I do it just so you can see, because I think this is a good test. Hip palpation at 90 degrees flexion. The gluteal aponeurosis at the greater trochanter. Iliotibial band. The iliotibial band rarely is painful proximally. If it's painful, it's usually in the mid-third with a fascia attaching it to the vastus lateralis muscle. Obturator externus. Let's see here. Well, I always test the obturator externus, a deep lateral rotator. Above it, the inferior gemellus, the obturator internus, the superior gemellus, and the piriformis. They all are within a very small 2-3 centimeters. I've had discussion with Lenny, and we're not sure, but we're going to try and figure it out how that affects gait, especially the stance space. Now, those tendons can be severely painful in a bad hip. But unless you look for them, you will miss them. You have to have this in your mind to look. That's, you know, gluteal obturator, piriformis, yeah. No, that's fine. And let's go. While prone. Do this with every patient. You practice it so it becomes part of your mind and you can do it automatically. You don't skip. Every time you begin to skip, you're going to find a patient or two that you missed something and said, oh my God, I didn't see it. Now, while prone, passive knee flexion. You're just going very slowly, testing both sides for quadriceps muscle tightness. Resisted knee flexion, posterior. Now, look what I say. That's L5S1. What else is it? Do not forget this. Do not forget. It's the best test for stability or for injury to the posterior cruciate ligament. If you go up and you push down and they're tender, slightly weak, you know that that ligament is sprained. Rarely is it torn, but sprained, and it can be a major factor in knee and hip problems. I've seen that repetitively. Why? Because I look for it. Active hip extension, S1. Passive hip extension, anterior hip capsule. That's another good test. It's sometimes very subtle. It isn't like it tells you right away. You feel both sides. And once you do this, you're going to say, oh, look at this. I found something. Resisted hip extension, S1. But also the best test for strain of the dorsal lumbar fascia at the posterior iliac crest. You're retesting your posterior thigh palpation now. If I do a bowstring test, I always want to do it again while prone. Sciatic nerve, medial hamstring, lateral hamstring, sacrotuberous ligament at ischiotubrosi, dorsal border of sacrum and posterior superior iliac spine. You're going to find, if you look for it, that the sacrotuberous ligament is a major factor in stability of the hip and pain in both the hip and stability of the lumbosacral spine. It's a major ligament. Well, let's see where I am. I'm sorry, here I am. Posterior thigh palpation again. I test the sciatic nerve, the medial and lateral hamstring muscles, the sacrotuberous ligament, the gluteus maximus muscle origins, the sacroiliac joints, the S1 posterior sacral foramen. If you have a disc injury at L5S1, the posterior ramus at S1 is going to be tender to palpation, and it's a neuropathic tenderness. You don't just push your hand down, you feel softly, and you'll pick it up with your hands. Once you identify it, you will not forget it. Posterior iliac crest at the dorsal lumbar fascia. This is missed by nearly everybody. They don't focus on it. And I told you once that I had a fellow with L5S1 spondylolisthesis. Had to have prolotherapy every several months just to feel better. Now he doesn't require that. Why? Prolotherapy again. We did the dorsal lumbar fascia, the posterior iliac crest, the iliolumbar ligaments, and we focus on the upper portion of the interosseous ligaments. We were able to do that. And all of that pain subsided. Now, lumbar interlaminar spaces, L3-4 for palpate. And people will tell you, oh, that's on the facet joint. No, you go inward and turn in towards the center of the spine. If there's tenderness there, if the medial branch is irritated, you will pick it up with your finger. It might be subtle, but you'll pick it up. spinous process stiff's the same. Then I do compression tenderness. There was a question asked me, everybody will be tender if you push down at 0.45 and 5.1. It's the extent or the severity of tenderness that tells you that there's a problem there. Now, you have this, I don't know how each one of you will examine people differently. Each one of you will have different ways. I'm not telling you to do it this way. I'm telling you to consider it and look at what you do and how you can make your evaluation better. What you want to do is be good enough so you feel confident that you know what problems the patient presents with. Next. Okay, thank you. Now we're going to do the hip. That's very important. And when I go over this, you will know. What, darling? Oh, are there any questions? Yes, there's a question. You have to help me so I get the question because I don't hear that well. Yeah, I hear that.
Yes. Yes, thank you for your amazing lecture, doctor. Actually, my question is about the previous topic about the solution.
Yes.
You said about ozone. I want to ask, when do you use ozone instead of dextrose for the ligament injection? Thank you.
When do I use ozone?
Yes, instead of dextrose. When do you use ozone and when do you use dextrose for the ligament problem? Thank you.
Good. Basically this. When I'm treating a knee joint, and I know the joint has been significantly injured, and I feel that there's a problem with the inner aspect of the knee joint, the synovium and so forth, I inject 5 to 10 cc's of 20% dextrose into the joint. I follow it with 10 cc's of ozone. The shoulder, 5 cc's, and dextrose into the joint. That's what I do. I'm not telling you, I can't say that what this does, but I can tell you the patients that I've treated always have done better. So this is an empiric treatment. Ozone can also be used in the low back, treating the sacroiliac, the interosseous ligaments, and the deeper ligaments. People say, I've treated many people, low back, shoulder, hip, and knee. And when I do that, I say, did the ozone help you? Yes, do it again. It's supposed to help in healing. Can I tell you exactly what it does? I can't. Many people will say it does many different things. But I want to warn you, I will tell you a story. There was a doctor, orthopedic medicine, in Pennsylvania. He thought that ozone was the cure for everything. Big signs across his office, ozone for the back, the neck, et cetera, et cetera. He had no basis to say that. He was shut down and lost his license. But it didn't mean that ozone was not valuable. When you see a person, like I told you about the person with a possible infection, ozone is a first treatment, it's a treatment of choice. For me, the shoulder, the hip, the knee. Now, in the low back, yes. Now, I don't have that experience. I can say 100 patients. All I can tell you is that the people that I've treated, and sometimes you just use a little bit of ozone over the treatment areas, in the low back particularly. And I've never had a complaint, and I've only had people tell me that they felt better with that. I hope that will answer your question. But I can't tell you that I'm an expert. I'm not, but I know where it works for me. Any other questions? Yes. There's another one here right now.
Okay. I have a question about the physical examination. You said you palpate the patient while standing for the tenderness. And you said you will also reassess the tender spot in lumbar extension and prone position. Why you reassess the tender spot in prone and a lumbar sacral extension again?
If I got your question right, palpation.
No, you
Yeah.
palpate the patient while standing. And you also reassess the tender spot in prone and
And
extension. Why you reassess in these two positions?
well, basically this. You want to be sure that where the patient has pain, and he places his hand on it, on his back or shoulder, etc. And you can make a mark at that level, if you will. You palpate while he's standing, but while standing, the paraspinal muscles, all the muscles in the low back are contracted, allowing him to stand, and you're not 100% sure. So then you have him lie down, let the muscles relax, and then you can palpate more deeply. And then to see if his complaint there is equal to what you find. Usually you will find that, but it gives you a better idea of exactly what structure, the facet joint, the transverse process, the iliac crest, etc. I think I would always, standing, you tell pain. Now, the shoulder's a little different, but the back, the mid-back or the neck, you always want to test them in a different position. And that helps confirm what you find. That's what you're looking for. Any? Yes?
So you mean that while you're standing because muscle is tight. So the palpation, the layers of palpation is more superficial. And when you're in prone position, in prone position and
Yes.
the spot you have the tenderness means that it's a deeper layer you have a problem. Is that what you
I
mean?
didn't quite hear, but I'm trying to, pardon me,
Okay.
my hearing is not that good, so I try.
Uh,
But look, always ask the patient, standing or sitting, where they feel the pain. Always have them put their hand on the pain and just don't say here, but see how they put the hand on the area of complaint. Always do that. Where you put the hand, and you'll find out that you'll see a consistency in what patients complain about. And that will immediately direct you to certain structures. Then you have them lie prone or sideline, whatever, in a different position to allow the muscles in that area to be relaxed. So you can feel the bony structures underneath, the facet joints, transverse processes, and the like. I hope that is that's the answer. I don't know, but I tried. Okay. Dan,
Yeah, okay, all of you have listened to Dr. Eck now for 2 hours. How many of you can tell me what operation he had? You've watched him for 2 hours. And tell me now what operation he had. That's all I'm asking.
what operation?
He's asking the audience.
Oh, the audience. That okay, Lenny? You have a hearing problem too? Lenny he's only 85, so he's younger, so he should be much better than I. There's no way I can hear you.
Walk across
Now I
the
hear.
podium, he had a special way of walking, which indicated to anyone who was looking what he had done multiple years ago. If you don't observe that, and that's what he's been stressing, you have to look, listen, and hear what you see, because that will give you the diagnosis. I have nothing more to add.
Back and forth, and Andrew and Frederick, you see what you think are, okay? No, this is very good, but you have to remember, Lenny is very good at, he's done this all of his life. He watches people walking, and that's good. Well, basically this. Oh, I gotta do this. There's a problem when you get older. Most of you don't understand that yet, but I will tell you, you will. Now, I used to go to the gym regularly. I did exercises that I should not have done. I developed avascular necrosis in my right hip. I have a right total hip replacement. And it still bothers me a little bit, but I'm better. My left leg, reasons unclear, I developed a clot in my femoral artery. Not good. I had an end arterial graft done about 17 years ago. It was all right for 13 years. They said, hey, it'll last for 13. I said, how does he know that? But he was right. The femoral artery clotted again. Then I had what do you call it? They took a graft around the femoral artery. It lasted for 3 months when it clotted again. So I said, that's not a good thing. But then we looked at my CT scan and I had collateral circulation through the deep femoral artery. I said, oh, thank God. I'm okay for this lifetime. I can walk and so forth, but I can't go long distances, but it doesn't bother me. Now, when you get older, you lose balance a little bit. I have to be careful. And Rayanne makes sure that I'm careful. But look, I'm still here. I can stand and talk, so I'm okay. But these things befall people, different things. But we have to learn to live with what we have, and that's what I've done. And I'm okay with that, as long as I can move forward and still work and do and teach. I like teaching. Frederick, I like to teach. Now the hip joint. I want to show you something. Okay, no. I gotta find out. Years ago, when I was trying to understand the hip joint, I did not. I was confused by how to figure out how to treat it effectively. Now, this was 20 years ago, or longer. Merriman, who was very much into sclerotherapy, which is now prolotherapy, the hip is the most unsatisfactory articulation that I've treated. I avoid treatment if any substantial amount of arthritis is present and discontinue treatment if there's no benefit after a second treatment. That was years ago. Today, I'm going to show you how you look at the hip, how you treat the hip, and what the future brings. You have to have a different mindset. You may have a way, each one of you may have a specific way that works, but I'm going to tell you the way that it works for me. Now, when you're unsure about a hip, you're unsure, is it arthritic or not? Just do a standing x-ray if you can. Joint space greater than 2 millimeters without sclerosis indicates a normal hip radiographically. You see on the right side, 4.5 millimeters and 4.5 on the other. This is a normal hip. If the patient has severe pain on walking and it is in the groin, you have to think of avascular necrosis, but that's usually not the case. Now, next page. Here. Now take a look at this. On your left here, 2 millimeters, 1 millimeter there. And then there's a disparity of pelvic balance. But now take a look. If you see this in your practice, you might treat them for pain relief with local anesthetic and a little corticosteroid. At this time, we do not have a way to treat this type of patient effectively. You may try, but don't expect to be successful. Now, the hip joint. Transmission of body weight to the lower extremity. Control of static and dynamic equilibrium. Now, Lenny will talk to you about gait, and he'll talk to you about all the things that the muscles about the hip joint have to do. The spiral alignment of tendons and ligaments assures stability and function in controlling the position of the lower leg. The range of hip motion is increased by movements of the pelvis and lumbar vertebral column. During locomotion, extension power predominates. Flexor power attains about 3/5 that of extension, primarily lifting the leg about 18% of body weight. I made a list here of all the muscles that control flexion, extension, adduction, abduction, medial rotation, and lateral rotation. No need to go over all of them, but you have a list of these, and when you're thinking about the hip joint, think about each muscle. I'm trying. Now, let me go back. Go forward one. Go forward one. Here. Now, when you look at the hip, and if we've gone over this with the low back, I don't want any of you to forget, when you see a joint, think fibroperiosteal junction, think myofascial tendon ligament injury, which would be micro or macro tears, think of nerve injury. Then, depending on the presentation of the patient, you think of inflammatory metabolic conditions that can magnify a painful condition as high sugar levels, uncontrolled diabetes, thyroid deficiency, adrenal exhaustion, protein deficiency, testosterone and progesterone-estrogen imbalance. Now, surprisingly, many people who do not respond as you would expect them to have something going on metabolically. Certainly, you look for pelvic imbalance, functional short leg syndrome. If you have a functional short leg, you can be assured that there's a discogenic problem here. I've seen that on many occasions. When you look at the hip, you always think of first you look at the low back, L3-4, 4-5, 5S1, because of referral pattern, and spinal stenosis at L4-5. I've seen patients with severe groin pain who had basically spinal stenosis at L4-5 and disc herniation. So when you look at the hip, you look at the low back and the hip. The periosteum we went over, so I won't review that. Again, contributing factors. Nutrition and digestion with protein deficiency, men, testosterone deficiency, progesterone, estrogen imbalance, hypothyroid. All of these can be major factors. I'm trying hard. Yeah. Now, pain is felt mainly in the groin and inner aspects of the thigh. When you see pain in the inner thigh or the groin, it might be coming from the hip. You focus on that. In your mind, groin pain is often referred from the L4-5 disc affected by internal disc disruption. Medial thigh pain is often referred by S1 and 2 nerve roots due to L5-S1 internal disruption. You have to rule that out in your mind. Pain can also be felt with the lateral hip, posterior, and buttock. Posterior hip pain is not uncommon and can cause radiation pain to the ankle level, usually in an L5 pattern. Often the pain is triggered by structures associated with the ischial tuberosity. When you see what is considered to be sciatica, obviously you look at the lumbar spine first, you look at the sacroiliac joints next, but you look at the ischial tuberosity in the posterior hip joint. It's clear. Again, assessing common hip. Have patient place hand on area where pain is felt. The presence of hip pain while standing, erect, or sitting. Often a limp is present, frequently painful. Inability to fully squat because of limited movement or pain. It's often made worse by walking, etc. When sitting is painful, always consider the gluteus maximus muscle being compressed at the level of the ischial tuberosity. I've seen that in patients. Lying upon the hip is frequently painful. Must evaluate the low back, sacroiliac, pelvis, and abdomen. So the hip can be very direct, but it can be, there can be other conditions that bother it. Now, anterior hip pain, right. We look for L4-5 referral, but we don't see it. These are the big issues here. I'll go over here. The most common cause of groin pain is strain of the rectus femoris muscle, straight head at the anterior inferior iliac spine, and reflected head at the upper border of the acetabular lateral to the anterior. This is a major factor, but it's usually related to three: sprain of the iliofemoral ligament at origin, within the body of the ligament, and at the insertion onto the intertrochanteric line. The iliofemoral ligament is also called the Y ligament of Bigelow. There are two arms. One goes to the upper intertrochanteric line, one goes to the inferior. Now, it's hard to deal with sometimes because you have the femoral artery and nerve overlying it, but there's a way to do it. Now, sprain of the anterior joint caps, often with some separation of the acetabular labrum. Now, often a young athlete, more female than male because their connective tissue is not as strong, will come with groin pain. An x-ray is taken and they see a separation. Oh, you need surgery. You need to have that repaired. Wait a second. Not until one of you, had the ability to treat them. You can treat that if it is really a separation only. You place either under fluoroscopy or you can do it blindly, but fluoroscopy is the way to do it. We've had patients that we've injected just 25% dextrose into that separation, thinking that that was the problem. And in a few months, the two people that I'm more became pain-free and never had that pain again. Just 25% dextrose. Now, when you see acetabular separation in your mind, you know where that is and what is immediately above that. the origin of the iliolumbar ligament. And more likely than not, it is sprain of the iliolumbar ligament rather than a separation of the acetabulum. Now, prolonged inflammation of the iliolumbar ligament and the rectus femoris to arthritic degeneration of the hip joint cavity usually starts at the origin of the iliofemoral ligament and anterior hip capsule. Now, this you never should forget. Never. I've heard over and over again, you have groin pain. Certainly, you take a standing x-ray or x-rays of the hip to see the alignment, yes. If you don't see anything remarkable that would require surgery, you treat that. What is the number one cause of hip joint arthritis? Not the only, but the number one cause. I didn't know. I wouldn't expect you to know. It is injury to the acetabular attachment of the iliofemoral ligament. When that happens, the rectus femoris muscle ceases to function properly, and this occurs over years. You get another injury, then all of a sudden, you see an arthritic hip, and you look, not all, but you see most of the degeneration is right in the groin area over the acetabulum. So you know that if you treated that person earlier and you understood and you knew how to treat that ligament, you're going to save an awful lot of people from hip, and you're going to save people who have chronic pain who cannot afford major care. This is, first, you have to have awareness. Second, you have to know how to do it. Then I go to 7, strain of the vastus lateralis, intermedius. These muscles can have a factor because they cause groin pain. You can identify it by resisted leg flexion, and it's at the level of the insertion of the iliofemoral ligament. Remember, the iliofemoral ligament is very strong, and you can have it. And also, I've seen it in patients now in the body of the ligament between the origin at the acetabulum and the insertion. And why? Why? Because the head of the femur can press outward, depending upon the individual and what they do. It can cause micro tears and inflammation within the body of that iliofemoral ligament. Now this, I don't think any of you realize it. This is huge. I don't want any of you to forget it if you're going to deal with hip. Strain of the sartorius, yes. And these are not serious problems. I treat that with neurotherapy. You don't see that often. Next one. Oh, next one. And we're at anterior. Oh, now look, no, go back one. Now look, no, go back. Go back one. Or well, forward one. I'm sorry, forward one. Anterior hip pain, then next. We'll get there. I need the next slide. Good. You see from this picture that there's not much here. Not much here, but the ligament goes from here, goes to here to here. It crosses this area. Now this is When you see that, you understand it. Next, I can do it. Here. The iliofemoral ligament. The Y ligament of Bigelow, intertrochanteric line, and just below the anterior inferior iliac spine. The pubofemoral ligament and the ischiofemoral are more membranous. Now, I've got to go back. Okay. No, I'll go forward. Now here. Now, I want you to take a look at it is where the arrow is. The intertrochanteric line, vastus lateralis, vastus intermedius, vastus medius, they all interact with the iliofemoral ligament. And this is why you can have pain in both areas. So when you look at it, you say rectus femoris, iliofemoral ligament at origin, midpoint, or iliopectineal line. Next. Again, this is Lenny. This is the iliacus. Now notice, as Lenny said, that this has a different function than the psoas major and the iliacus. It comes down here. They look the same, but they're not because the iliacus attaches to the anterior hip joint capsule, and that provides stability and stance. And this is Lenny's contribution to me, and I'm happy that he did it. Now, lateral hip pain, not uncommon. Gluteus medius and gluteus minimus muscles that are attachments to the greater trochanter via the gluteal aponeurosis. Very common. And when you see this, you first disinflame it and then you strengthen it. And that problem should be resolved. Trochanteric bursitis does occur, but uncommon. Localized strain of the gluteus medius and minimus muscles overlying the outer ilium, which does occur. You treat that separately. Strain of the gluteal aponeurosis at the lateral lip of the iliac crest. This is lateral hip pain. Then with the patient lying on his side with the thigh flexed to 90 degrees, you look for the obturator externus tendon at the greater trochanter, the obturator internus and jejunum muscles, the greater, and the piriformis. You can palpate that with your hand. At first you put it over, so geez, this is just tissue. But if you're careful with your hand, you'll identify the obturator externus, the piriformis muscle group, I call it. And this can be very important in treating a hip joint. Then piriformis, the strain, the hip capsule and iliofemoral ligament at their acetabular attachments. There's a way of doing this. You can do it anteriorly, placing a needle down. If you can do it by feel, I do it by feel. Ultrasound, certainly. There's another way. You get the origin in the body, and you go laterally. Hello? You go laterally. You have to be very careful with that. I use a 3-inch needle on a male, and you don't plunge it in. You feel with the needle tip. First, you pick up the acetabulum and the anterior inferior, and you go right below it, and you feel for the ligament. I've done it. I know how to do it. I know what to feel for, but it's been trial and error over many patients. But I say, you can do this. You can do this in your office. Once you feel confident, you then have control of the iliofemoral ligament. And if you have control of the iliofemoral ligament, for the most part, you have control of the hip joint. Doesn't mean that there are other issues that you have to deal with, but you deal with that. If you can do that, then all the other issues are much easily treated. This goes back to the posterior. Now you see the sacral tuberous ligament here, and you see hamstring muscles, you see the quadratus femoris, and you see the trigeminalis inferior and so forth up to the piriformis. All of those muscles can be a source of pain and dysfunction. Now, I want to remind you something. And Lenny has pointed out when you watch a person walk, sometimes you don't know if it's abnormal. But if it's abnormal, there's a reason. You would like to know the reason because that would be helpful. But here, all of these structures have a purpose. And sometimes you put the needle onto the attachment site, the fibril, and they're very tender. But when you touch the muscle itself, you don't feel tenderness. So you have to develop an insight what you are looking for. Like gluteus medius and gluteus minimus attachments. And when you see this, it's obvious, and they respond well to treatment. Now, here's the iliotibial tract. I have seen, I've had patients where they're, I'm getting mixed up here. Where the tensor fasciae latatum muscle has tender areas up high from the iliac crest down to the tendinous portion. And those really are treated by neural therapy. But the larger number of patients who have pain here to here, and it's hypersensitive, it means that they have injured the attachment site to the underlying vastus lateralis muscle. Posterior hip and low back pain. When they say they have pain in the buttock, and they usually put it in this area here, don't automatically say to yourself it's from the low back or sacroiliac. It well may be, but do not say it to yourself automatically, because now that you know about the sacrotuberous ligament and the origin of the ischiotubral and sacrotuberous ligament, you have to rule that out. Have to rule that out at posterior hip. Then you go up and you look at the low back, dorsal lumbar fascia, posterior sacroiliac joint and ligaments, gluteus maximus muscle, and sacrotuberous ligament. And then you have a very good idea of what's wrong. The medial hip and thigh, that is usually the adductor magnus. Usually you find tenderness at its attachment to the adductor tubercle or the medial femoral condyle. Otherwise, you feel it certainly can be at the attachment of to the pelvis at the lateral border of the ischiotuberosity, but very commonly it's the fascia that surrounds it that is a source of pain. Well, this just shows you when you have posterior buttock pain, always start up high and be sure that you're what you're looking for. Next. Again, the sacrotuberous ligament. This ligament is not appreciated by the majority of physicians who do orthopedic medicine. I hope after today, you all will appreciate the function and the importance of this ligament starting at the ischiotuberosity down below. Next. Oh, good. Story. Young lady. Do you hear me? Yeah. Young lady who from her late teen years felt that she wasn't doing right by herself if she didn't run several miles every evening. She had a slight shortening of the right leg, maybe it was just 2 or 3 millimeters. That's all it was. Then the upper joint stresses caused inflammation at the attachment of the iliofemoral ligament, probably with tears extending into the body of the ligament. Necessitated a total hip replacement. Age 40. What was she? She was a vegan vegetarian. never ate protein. She could not heal. If this was identified early on, this could have been saved. She did go to the orthopedic department at UC San Diego. What did they tell her? Come back when you can't walk and we'll do a total hip replacement. Here, if you identify this early, you can treat it effectively. This is what, she's had this for 15 years, had to stop running, and now she's a bit older, so she's more modest. The only reason I bring this, I want you to see where the femoral nerve is on the left sciatic nerve. When you're in that area, use your hands and identify structures, and you will never hit this. If you go in blindly, you will hit it, I promise you. Now this shows you just what college athletes find, and I just bring this up to you. Frequency of reported hip and groin adductor tear, partial or complete, hip flexor tear, iliopsoas sartorius tear, internal rotator, hip contusion, hip pointer, abductor muscle tear. But these are all in young college kids, and they probably all recovered. Now, what you see here is our two arthritic hips. But look where you see the arthritic degeneration. Look. It is at the origin of the iliofemoral ligament and upper joint capsule. Once this gets started, everything gets started. Now here, 75 years old, severe right groin pain, doing various exercises. MRI scan was, it looked normal. You didn't see anything, but look on the right. Vascular necrosis. That's avascular necrosis. So that was done in 2015, and it's still working. This was a 45-year-old male. This is before we really knew. He came in with severe groin pain. He was very athletic, and he was hypermobile. He went to a surgeon. He said, oh, you need to have a surgical repair. He wasn't for that. He came, and we injected 25% dextrose right into it. 3 months later, pain-free. The pain has never returned. Simple. Always do simple first. This is examination of the hip. Frederick, do you want us to examine somebody? Okay. Who's a volunteer? Can we use him? Can we use him as a subject? Okay. He doesn't have to take anything off. Just take his shoes off. Have him take his shoes off. Rayanne, will you hold this for me?
Just come down that way, please. Thank you. Come over.
Okay, Rayanne. You'll have to tell me. You're going to be our specimen. Okay? Now, first, we're looking at his hips. We want you to walk there and back first. Just walk. Now, normally you'd have shorts on and so forth. Okay. Yeah, just walk straight ahead normally. Walk normally.
Shoes off.
Yeah, shoes off. Yeah, just like you are.
person.
Go, go. Walk, just walk. You watch. You already see there's a little limp on one side, don't you? Now come back. On his right, take a look. There it is. Now, well, but do you have any hip pain at all? How old are you? You're a young man. You're a young man. So now we've looked at walking. Now sit here. What do you see? What do I see? It doesn't mean that there's a problem. It doesn't mean that. It means what you're thinking. Oh,
Pause.
oh, okay. Thank you.
So hearing it
Yeah,
on both sides.
thank you. Put this over here. Thank you. Is that good? Yeah, good. Can you hear me? Now,
It's open.
what did we see? We saw a little lurch. No pain. Trying to see what we find out. But now look at his feet. He has flat feet, one. No. Put that in the back. What you notice, he has early on bunions here and here. And what is he doing? He's going, oh, look what he's doing. When he walks, he's putting more weight on the great toe. And then when he does that, the toe is going laterally, but he doesn't have pain. So I think if Lenny saw this, he might recommend but look, now, if I do this, you have to tell me, is there any tenos along in here? Not really. Yes, okay. Right here. So what is he telling us? We watched him walk, not normal, no pain. We look at his feet. He does have, his arch is very shallow. And look, here, and here. His stresses are on the bunion areas, and already we come up here. I don't mean to, it's okay. Now look, what we're doing, you have to tell me, because I don't want to be hurting, any tenos along in here. It's just up here. It's right here. And there's a prominence here, so we know there's a slight osteophytic reaction. We just make note of it. It's nothing big, but that's what we're looking at. But you're walking, other than that, non-painful. Lie on your back for me. The medium, the malleoli look essentially normal. And you look to see here if he has any laxity of the medial collateral ligament here. Now, there's a difference. Subtle, doesn't bother him, but look, I'll tell you what I'm feeling. I come up here, I just bend, I feel here, there's laxity. Laxity. Not a lot, we're talking little. Now look here. None. Wait a second. So we know we know he's compensating. We know that. Now why we don't fully know, but we know. Then I'm looking at the hips. What I do, first thing, just pull and rotate. It feels normal to me. That's normal. Then you might want to do this. I want you to take a look. I come out here. I do this, and it's very subtle. It's there. You have to tell me if this is tender. I don't want to put words in his mouth. I just want him to tell us if we found any. Anterior superior spine, here. Slide it into. Now, right here, you tell me if you have any tenderness in here. What? Yes? He does. Where's my finger? Over the iliofemoral ligament. It's tender, but it's not a big issue. But it's right here. Is that correct? Now, compare. You have to tell me. I go to the other side, and I try to find out the same area, so I'm not fooling myself. You always have to say to yourself, am I fooling myself when I see a finding? Because you can do that, and you say, geez, now let me go in here. You felt this. I'm roughly on the same area here. Not so much. So we know that there's an issue here. No pain, but we observed him walking. Then we noticed he had flat feet, and if you notice, this is me, I'm not going to say it's you, but I put my finger here. This is fuller. It's right here. And there's a bony prominence here, and this is where you have your tenderness, right? And it goes down to here. So I know there's stress. This is minor. You would treat this minimally, but we're using you as a specimen, all right? Now, I like to look at straight leg raising here. I've seen people just go up, oh, there's nothing wrong with the person. You never do that. You feel, and what you feel, it might be just stiffness, and it's normal for this person. Now, I get them up to 90. Were you very flexible in your youth? What? Let's take a look here. Now, look at this. Dorsiflex, put stress on, gets up to 90. Huh? What did we just see? I'll go over it again. These are subtle things. They go here. I dorsiflex a foot, I'm feeling. That's why you go slowly. When you dorsiflex, you put tension here. Now look, I get right here at 90, so I call that normal, but I get tension here, so that could be normal. But now we go over here, and let's see, again, right there. Look, there's a difference, isn't there? Right? Now, you go back and you feel. The issue here is not to fool yourself. But I feel tension around the ischial tuberosity, so I know that his body is compensating. Now, if you knew this, you might just exercise or an arch support or something like this. So we're learning about you. Now, so we go here. I'd like to do this. If you bring a person, in a young person, you don't expect anything. You do this. This is normal range, and you ask if it's painful. That's normal range. Normal range. But if you did this and you went like this, an older person, and there's a block, you know it's arthritic before you go any further. So you do external rotation, internal rotation, and adduction. That's quite normal. You do hip overflexion, quite normal. And he is a little bit hypermobile, but that's nothing wrong with that. Nothing wrong with that. You see, now I come here. Take the thigh to the abdomen slowly. You're feeling for resistance. It may be pain-free, it may be painful. Now you have to call that normal. I would say that's normal, definitely. But now let us do it, let's compare. Look. You wouldn't have known if you did this alone, you say that's normal. But now we know here, I go here, I'm feeling. You feel with your hands. It's right there. Am I right or wrong? It's right here, isn't it? You see what we have learned just by doing a little hip evaluation. Now we want to check, let us say, the iliofemoral, the quadriceps muscle. So take this leg, bring it up here, hold it. Do not let me push it down. You be tough with me. Bring this up, hold it, tough, tough, tough. Bring it up, hold it, tough, tough, tough. You can't do it, can you? We just talked about it. The intertrochanteric line, the vastus lateralis, and he's got a strain phenomenon here. You're only 33. No pains, okay. But you did. How long ago did you sprain the ligament? Oh, 4 or 5. So he's telling us he had an injury. But so that we factor that in. But listen, we didn't know him. But we see a problem here, do we not? We see a problem here. We see a minor problem here. Now, he's done well. And, you know, if he was coming to any of you, you might just recommend an art support or better shoes and so forth. But we're looking at you thoroughly, okay? Now, we know there's a problem here. Now, when you come up to the anterior superior spine, the anterior iliac, anterior inferior, you feel the anterior, then you go laterally, and your hand is right over the reflected head of the rectus femoris, attaching to the acetabulum. Then I'm going to go here. Is that tender to you? It is. Now, let me go down here, I have to find it, I'm sorry. It's right here. Is that tender? What? Right here? I'm right on the iliofemoral ligament. So we know there's a strain. It's minor. You might just want to watch this. Observe it. Now, lie on your side for me. Face that one. When you lie on your side, you just like to palpate the iliotibial band and the underlying, just for tenderness. You don't expect it, but if it is, you begin to look. You go to the greater trochanter here, and if the gluteus medius and the minimus attaches to the anterior border, the medius to the lateral surface. Now, if you press right on the bone, no. The tendons attach just underneath the superior border here. I'm right on them. And that when you do that, and you're going to treat this, you make sure the needle goes into the fibroperiosteal attachment along here. Now, when you come up here, this is the and I can feel it, But then, you know, go a little bit further, you're at the upper end of the vastus lateralis muscle and the upper part of the Y ligament of Bigelow, or iliofemoral ligament, right here. Is that tender to you? It is? Yes, it is. You see what we've learned? What we've learned just by being careful. And just by feeling in your hands, you remember I tell you use your hands. It's right here. Now, let's say we're going on. So we're going to do this here. I'm going to take this leg up and straighten this out. Now, here's the greater trochanter. And if you pick up the superior border here, lateral border here, and if you go along here, you feel the obturator externus. I have to find it. It's right here. That may or may not be, and I don't expect it to be. Then you come up here and you feel a fullness. Piriformis, obturator internus, and gemelli right here. And then if you go down here deeply, you feel the upper border of the acetabulum. But now, if we were going to treat the iliofemoral ligament, this is one way you can go anteriorly, but it's very easy to place a needle in here. You aim for the acetabulum. You don't go boom like that. No way. You aim for the acetabulum behind the anterior inferior iliac spine. Then you take it down and you keep it as close to bone as possible, and you will feel the ligament. In some, the ligament is very thick, and some it's very fragile. You can then take the needle over if you want and go here, and here is the, from this point, is the intertrochanteric line, and you take it down here. You see all the things that you can learn. And look what we've learned from you. He's got a good hip joint. Motion is fine. But he has residuals of an old injury. 33, young, he may never bother him. But at least you put that on your record and you check. If he gets painful, then you know what you have to look for. Does this make sense? Does this make sense? Now, we're going to pretend that we're going to do the gluteus medius muscle test. This is for sacroiliac joint dysfunction. So what we do is bend the bottom leg, straighten the top leg like this. Then you roll his buttock over just a little bit. You take the leg, the knee is straight, bring it back and up. Then I ask him to hold it. You don't put your hand here, above the knee here, because this is, that's strong. Let's say he went down, it was weak. Geez, that's weak. Then you take your leg like this, you bring the thigh to his chest like this, and you hold him like this. About 20 seconds, maybe 30. Hold. It resets the SI joint. You know, to say that I fully know why I don't. But you do it for 30 seconds, and you bring the leg back, straight, back up, like, hold it. And strong. If it were weak and became strong, you know that the SI joints are a problem. Now lie down on your tummy. Now, can you loosen this a little bit? We're making him work. Now look. From here to here, low back pain. That can be ligament, it can be muscle, it can be disc, it can be spinal stenosis. This is what you're looking for. Now, here you can feel the iliac crests. Here's the posterior superior. You put your hand like this. And I inject like this to get the interosseous ligament and the iliolumbar here. Then I take a needle and I go directly down and try to get right onto the dorsal-lumbar fascia, number one. Now, you come down here. You have to palpate it, and it has to feel like you have the major part. You don't guess. You don't come down. Here's a gluteal fold. You feel it. You hear. Then you can mark it. I put a little bit of local anesthetic, and I take the needle. I want to get right onto the bone. Then you find out, is it tender? Yay or nay? Then you go medially, you walk up, yay or nay. If it's tender, you have an answer. Then you treat that maybe with 3 to 5 cc's of, and then you go over to the inferolateral angle of the sacrum here, and you feel it. And you go down and you pull up and you go right along here to the iliac crest right here. You're getting the sacrotuberous ligament and the overlying gluteus maximus muscle. Then when you do this type of maneuver, you get the interosseous muscle, and up high, you get the iliolumbar ligament, and then you come over here and you can get that. And these are major. If you know you got a problem more laterally here, think in terms of quadratus lumborum. Always thinking that. And you go, oh, there it is. I can feel it. And you put a needle obliquely down like this. If you have ultrasound, that might be more easy for you, but you can do it blindly. Then this is something I don't think any of you have seen. I just want you to think about it. I'm not going to tell you to do it, but this is the major part of treating the low back. And then identifying the sacrotuberous ligament and gluteus maximus, identifying the interosseous ligament, iliolumbar ligament, and dorsal lumbar. Then you go out here more laterally to pick up the quadratus femoris, here more laterally, and then you can do the facet joints as well. And then sometimes you do centrally. If he bends backward and he's very mobile, you definitely treat the center. Does that make sense to you? I hope. Any questions? Thank you. Thank you. Well, that was good. Well, I think we're done. We had a long afternoon. I hope it was worthwhile for you. I just talk sometimes. I've done this for many years. I know what I'm looking for. And you'll all get more and more experience with each year, passing year. And you always look at each patient as a lesson for you. How can I make a better diagnosis? How can I get that patient well again, if possible? If you do that in your entire career, you'll be very pleased, and you'll be able to earn a living satisfactorily. Okay, we're done, sir. What? You have to speak up, Frederick.
I think that iliofemoral ligament. Yeah, you mentioned
iliofemoral?
Yeah, the acetabulum side is more easy to injury than femoral side.
You can go anteriorly too.
Yeah. I mean, which part's more?
What?
Which part is more important for the ligament?
The biggest part, you want the origin. Why? Because you saw in all of these x-rays of arthritic hips, that's where the inflammation starts, because because the attachment is very small as the ligament becomes larger. As it becomes larger, it doesn't have the same stress on it. So you want to, laterally is fine, but you can also go anteriorly. And you pick up the anterior inferior iliac spine and just go to the side of it and down. And the needle tip will tell you if you're in the ligament. You follow it down. I'm telling you, there are many different ways. There's no single way of doing anything. Each one of us will develop a habit pattern that works for us, and that's fine.
No, it's the teres ligament.
What?
Is the teres ligament important?
Say?
The teres ligament, because the one ligament connect to the femur and the pelvis.
Iliopectineal, the intertrochanteric line.
The ligamentous teres.
I'm not getting this.
Yeah, ligamentous teres connect the femur and the pelvis.
Yes?
Do you think that is important?
Oh, yeah.
So do you treat it?
Right?
Do you treat that ligament too? The-
Yeah,
just the femoral ligament.
the femoral ligament. Okay. My mind is going a blank. I'm trying to think where that is. Where,
有那个图。对。
A lot of MRI reports,
What?
a lot of MRI reports will say that the ligamentum teres or round ligament is torn or injured in some way, and we just wonder if you find it important. Round ligament is like a tiny ligament attaching a scapulum to.
no,
Yeah, okay.
it's not that important.
Okay.
The ones I told you are important. The only reason I can tell you that is that I've treated many patients. So I've treated many hips. When I started years ago, I felt very insecure. I was very unsure if I would be of any help. In the last several years, every patient that has a normal hip can be treated effectively. Can be treated, but if you have any question, you do a standing x-ray. You make sure where the pelvis is, or the hip joint. You make sure of that. Once you know that that's okay, there are certain, you'll see in one of my talks about ligament tears. In the shoulder, they speak about the, supraspinatus, infraspinatus tendons. Obviously, if you have an acute tear and you come in, you'll have it repaired straight away. The patient comes to you weeks or months later and it has retracted. Your ability to pull it down and repair it is very low. You can try it, it doesn't work in a large number of people. Tomorrow I will show you a man who's 51, who's active in jiu-jitsu. His right shoulder has a complete tear of the rotator cuff with retraction. The long head of the biceps muscle is completely torn. He can't do this, but his deltoid, pectoralis major are so strong he can throw people over his shoulder. You say, what? How did this happen? It shows you what can be done. When you don't know and you see a chronic tear, you say, oh, terrible. A lot of things you can use other things, and certain tears may be important, may not be. And I think sometimes it depends on the individual. But I've seen several women who have had chronic shoulder pain and complete tears of the rotator cuff for whatever reason. And they function very normally. They may not have full elevation, but if you get your deltoid muscle strong, you do. This man has full function of a shoulder with a complete rotator cuff and long head of biceps. What? There's a lot can be done. When you don't know, you are in a quandary. When you have seen, then you know you can do a lot of things to help people. The whole issue here is to get people through life without pain and with as good function as possible. That's what our job is. Your job too. Everybody. Okay, thank you very much.
Thank you. Thank you.
Thank you. Thank you.
So tomorrow will be 8:30, right? Okay. 对吧? Oh, yeah, we will start at 8:30. And tomorrow, Lenny will talk about foot, ankle, and biotensegrity and the ligament. So it's a very fabulous speech tomorrow. And let's thank Dr. Bjorn Eck again. It's a really hard work. Okay, so see you tomorrow. If you have any question, maybe you can write it down in the mail to us. Maybe we can ask them later and feedback to you. Okay. Okay, see you tomorrow.
OK，所以那个线上的如果有问题的话，就还是可以打上去的话，我们会收集起来，明天问老师这样子。那个什么聊天室的要先按，因为要那个用关掉那个。
等一下网络设定一下。
对，我们等一下来用网络的东西。
对，